well. I have asked to curate diet for CKD patients with dialysis, without dialysis, salad, to make a salad. And they have done very well. And we have given first, second, third prizes to all the ASHA workers. Next slide. So this is how it was done. Next slide. These are the prize distribution. Next slide. Yes, next slide. These are all the ASHA health workers of Renigunta, Karakambadi and Mangalam, all the 3 areas nearing our hospital. They were all very happy and they said they would definitely educate the population about prevention of kidney diseases. Next slide. And it was all well covered in the media. Next slide. And this is our Dr. Ratna Prabha, Assistant Professor at Department of Nephrology, Visakhapatnam. She has delivered a lecture on the importance of CKD, CKDU prevention, and the importance of dietary restrictions in chronic kidney disease. Next slide. Yeah, she has received an appreciation for that. Next. And this is Vijayawada. All the nephrologists of Vijayawada, they have participated in a walkathon under Dr. Ramanna sir, and it was well covered in the media. And all the lady nephrologists like Dr. Radhika, Dr. Sirisha, they all participated in this walk. Next. Yeah, these are the slides. I think we have tried our best, and hopefully we will do a lot of activities in future. Actually, I shared the. That's it, ma'am. We have photos of Jiki madam, ma'am. Actually, I added it, but it was missed. I would just send it, ma'am, so that it could be projected. Saivani, madam. That's it. That's it, madam, from my side.
Nice. Dr. Saivani has got the photos. Yeah.
Yeah,
just project them.
I'm just 1 minute. Yeah.
Meanwhile, I think it is
very nicely done. Shiva Parvati AP has done a wonderful job till the time you are uploading the photos. So the diet and all the ASHA workers, that idea has really appealed to me, apart from all the other works you've done. So very wonderfully done. So
thank you, ma'am.
This is the walkathon done in Kurnool Medical College under the leadership of Jiki madam.
Yeah.
So what I appreciate about Parvati is, though she's not in a teaching center in a hub city, still she does.
Thank you, ma'am.
Saivani as well, and many of you who are not affiliated to big hospitals. So finally, that doesn't make a difference.
Okay, so I think we have a next program.
Next talk is by prevention of recurrent renal stone formation by the Fanishri, Dr. Fanishri. Dr. Fanishri is a assistant professor in nephrology in Katuri Medical College. She graduated from NIMS. Dr. Fanishri?
Yes, madam.
Share your screen, Fanishri.
Yes, madam. Is it visible, madam?
Yes.
Good afternoon to everyone. Swanlata madam, good afternoon, madam. How are you?
Yeah, good afternoon. How are you?
Good, madam. So thank you for giving me this opportunity to speak today. I'm Dr. Fanishri Alapurti. This year's World Kidney Day, the theme for World Kidney Day was caring for people and protecting the planet. So with this theme in mind, we will be discussing briefly on renal stone disease, its preventive strategies, environmental effects on stone disease and vice versa, and public health strategies that could be implemented. The global burden of kidney stone disease has been increasing. The prevalence is around 10 to 15% in developed countries and 15 to 20% in developing countries, including that of India. There is a very high recurrence rate with 50% of stones recurring within 5 to 10 years. And we are seeing an increasing incidence in younger populations. The CKD risk for renal stone disease is at an estimated hazard ratio of 1.4 to 1.5. And
అది జనరల్ వార్డులో పేషెంట్ మిస్ అయ్యారు, పలకరించేసి వస్తాను.
And for ESRD is 1.79. As we can see in this map of India, the ones that are highlighted in red, Gujarat, Rajasthan, Haryana, and Punjab, including Delhi, were the old kidney stone belts, where which there was a lot of prevalence for over 20 years. But the ones highlighted in green are the new emerging kidney stone hotspots, or the new stone belts, including West Bengal, Maharashtra, Telangana, Andhra Pradesh, and southern parts of Karnataka. So there is a change. There is a change in the evolution of the kidney stone belts from more of northern parts of India to the southern parts. And basically, the renal stones are abnormal formation and retention of solid phase organic and inorganic concretions in the lumen of the urinary tract. Initially, it was once viewed as a limited disease simply managed by a urologist, but now it is being increasingly recognized as a complex systemic disease with an underlying metabolic, genetic, and endocrinopathies that require thorough evaluation and care. They are also a predictor for metabolic and cardiovascular complications. Here we can see that in one analysis, it was revealed that renal stone disease has 31% increase in the risk for myocardial infarction, despite adjusting for known risk factors for CVD. How this metabolic syndrome affects kidney stones, there is a lot of inflammation. There can be crystallization of calcium oxalate, increased oxalate excretion. There is decreased urine pH and increased uric acid production and excretion, which may in turn lead to renal stone disease, CKD development, and thereby increasing CVD risk and mortality. Coming to the traditional risk factors for renal stone disease, we know the non-modifiable and modifiable risk factors, where we can focus more on the modifiable risk factors like lifestyle habits and dietary nutritional factors. There is a lot of westernization of our diet with highly processed food, increased meat consumption, which has adversely affected the gut microbiota and caused dysbiosis, thereby increasing a lot of inflammation, and there is a lot of diseases, including that of the kidney, happening in the body. Whereas the Mediterranean diet, which includes more of fresh fruits, vegetables, legumes, and olive oil, has the capacity to reverse this dysbiosis of the gut microbiota. And these lifestyle changes are definitely risk factors for renal stone disease. Others include metabolic disorders, urinary composition, hypercalcemic disorders, low urine output, which is caused by dehydration, and supersaturation. There is if there is a recurrent renal urinary tract infection, then there can be an abnormality in the urinary pH and increased bacterial growth of causing recurrent stones. Genetic predisposition and hereditary disorders, anatomical abnormalities of the kidney, such as medullary sponge kidneys, the uretropelvic junction stenosis, or pelviuretral duplications, polycystic kidney disease, and horseshoe kidneys. Risk factors like hypertension and obesity are also known to increase the risk of renal stone formation. Now the focus is on climate change, where global warming, the occupational hazards in India, a lot of heat stress, and farmers being exposed to heat, and also pesticides contamination. So there is also seasonal variation, more in the summers than in the winters, lithogenic drugs, and inflammatory bowel disease. So there is the recurrence rates are very high for these stone disease, with 50% in 5 to 10 years and 75% recurring in 20 years. So what are the risk factors for recurrence? In history of multiple prior stone episodes, younger age at the onset of the first episode, male gender, family history of kidney stones, and higher BMI. There are certain stone characteristics that can predict recurrence, which is presence of 2 or more stones across both the kidneys, presence of stones in the renal pelvis or lower kidney pole, and stone composition consisting of uric acid, struvite, or brushite. The most common type of stone that we see is calcium oxalate, followed by calcium phosphate, uric acid. Struvite stones are seen in infections, cysteine for rare genetic disorders, and drug-induced account for 2% of the stones. Coming to the mechanism of stone formation, here, as we can see in the first picture, there are basically two mechanisms for stone formation. One is the fixed particle mechanism and the other is the free particle mechanism. The fixed particle mechanism is where there is deposition of calcium phosphate in the interstitium, growing outwards and reaching the renal papillary surface, which becomes exposed to the pelvic urine, and it establishes a nucleus for deposition of calcium oxalate, leading to the formation of the calcium oxalate stone. This is called the Randall's plaque. And coming to the free particle mechanism, here calcium phosphate, uric acid, or cysteine crystals are formed within the tubules, moved with the urine, and aggregate and plug the terminal collecting duct. These plugs are called the Randall's plug, which are the lesions that are exposed to the pelvic urine, predisposing to deposition of either calcium phosphate or calcium oxalate on top of that and leading to renal stones. Our urine contains natural stone inhibitors, that is citrate, uromodulin, magnesium, and others like pyrophosphate and osteopontin. Whenever there is an imbalance between stone inhibitors and stone promoters, there is an alteration in the pH of the urine. It increases the supersaturation, leading to nucleation, growth, and aggregation, ultimately causing nephrolithiasis. So what are the preventive strategies for renal stones? Key preventive strategies include adequate hydration, dietary modification, weight management, metabolic evaluation of recurrent stones, pharmacological therapies whenever required. Hydration, we need to educate all our patients on adequate hydration, at least fluid of 2 to 2.5 liters per day. How do they know whether they are adequately hydrated or not? We ask them to look at their urine color. If it is pale yellow to straw colored, then they are good, well hydrated. If the color of the urine is darker, then they definitely need to drink more water. How does it help? It dilutes the urinary solutes and crystal formation. It reduces supersaturation and thereby reducing recurrence of stone formation. And with the community perspective, we need to promote safe drinking water access and also increase reusable water bottles rather than single-use plastics. Coming to the diet in renal stones, we all know there's sodium, increased salt in diet can also predispose to stone formation. So daily sodium intake of 2 to 5 grams per day, reduce red meat, increase fruits and vegetables, maintain adequate calcium intake through diet. So there is always a debate between dietary calcium versus supplemental calcium. So it is recommended that we do not take more than 500 milligrams of calcium per day if we are at a risk of renal stone development, or 2000 international units of vitamin D and 500 milligrams of vitamin C supplements per day is not recommended. And we need to avoid high oxalate foods, salty and sugary, highly processed food, and meat. So always go for fresh fruits and vegetables, a lot of water, and we need to educate our patients on whenever a patient comes to our OPD with a renal stone, we should not wait for a recurrent stone to educate the patient on preventive diet or preventive strategies. We need to encourage more fluid intake, fresh fruits, citrus fruits intake, and moderate protein and limiting red meat, avoid supplementation, and we can encourage them to eat more calcium in the diet, which does not have much effect on stone formation, which is a myth that patients do consider that eating more, having more calcium will increase the stones, and also avoid salt and vitamin C supplements. Coming to the pharmacological interventions, we usually prescribe thiazide diuretics, which increases the calcium reabsorption in the tubules, and potassium citrate to alkalinize the urine and dissolve the stone. In case of hyperuricemia, allopurinol and febuxostat are recommended. And for chelation of cystine stones, D-penicillamine can be used, and pyridoxine for primary hyperoxaluria, which reduces the oxalate synthesis in the liver. And lumasiran is a drug that was FDA approved in 2020 for treatment of primary hyperoxaluria, which is given as 3 milligrams per kg monthly loading dose, then every 3 months. Tamsulosin in case to facilitate stone passage. So what's new in the therapeutic strategies? Probiotic therapy with Oxalobacter formigens. The new drugs that everybody is interested in, SGLT2 inhibitors, GLP-1 analogs. Then comes lumasiran, the FDA approved drug, and nanomedicine. So this Oxalobacter formigens is present in the colon of in the colon, where it binds the dietary oxalates and degrades it, reducing its absorption and thereby reducing the lithogenic risk to the kidney. GLP-1 analogs they are neutral to protective profile against new stone formation. They may not have a direct effect on reducing the lithogenic risk. However, by significantly affecting the metabolic parameters by improving insulin resistance, reducing inflammation, and weight management, reducing the BMI, they can lower the urinary oxalates and uric acid secretion in the urine, thereby neutral to protective effect on the kidney, on the renal stone profile. Whereas SGLT2 inhibitors, there was an active comparison between SGLT2 inhibitor users and GLP-1 analog users with a median follow-up of 2 years. They found that the nephrolithiasis incidence is 2 per 1,000 patient years in SGLT2 inhibitor users when compared to 4 in GLP-1 analogs. This is a stark difference. There is another study where adult patients with type 2 diabetes were initiated on SGLT2, DPP4, and GLP-1 analogs. And they have compared the two sets, SGLT2 versus DPP4 and SGLT2 versus GLP-1. So they found that SGLT2 treatment group yielded a lower cumulative incidence of nephrolithiasis compared to DPP4 and GLP-1 analog group. So SGLT2 inhibitors can be used in preventing recurrent stone disease as per these studies. So this is a newer concept of nanomedicine. This is an article from China, which was published in International Journal of Nanomedicine. The basic concept of this is they have developed nano particles that can be biosensors that can enable the accurate assessment of urinary ion compositions in vitro. Then they have developed contrast agents using iron as the material used for contrast, which is known to improve the signal to noise ratio and enhance the image clarity. And using iron as a contrast medium in MRI and CT, it will drastically reduce the risk for contrast-induced nephropathy for RCKD patients. And they have also used nanoparticles to have an effective drug delivery as carriers in urinary tract infections or sepsis. And they have also trained these nanoparticles to modify the physical and chemical properties of bacteria so that they can eliminate the bacteria completely in case of recurrent urinary tract infections that are very drug resistant and difficult to treat. So this nanomedicine is a relatively newer concept and is still under research. There is a long way to go probably for this nanomedicine to come into practice. till now they have only tested on cells in the laboratory and probably animal studies, but it might still take time for this, but it is definitely a promising advance. Coming to the planetary and environmental impact, we know the kidney disease treatment has impact on environment, and this environmental changes contribute to climate change and all in turn affecting the kidney disease. It is a vicious cycle, but we need to take interventions to somewhere break this cycle of adverse effect. So healthcare sector accounts for 5% of the global emissions. Here in this picture, if you can see, we may not even think that visitor travel, staff commute, patient travel also have a lot of effect on the carbon footprints contributed by the healthcare. Anesthetic gases and meter dose inhalers, water waste, building energy, and other supply chains. The supply of medical equipment or medicines also have a carbon footprint that is being contributed by the healthcare. And dialysis consumes a lot of water and energy, high plastic waste. All these environmental effects have changed the climate through radiation, through increased global warming, through pollution, or and all this will in turn have effect on our cellular metabolisms, increasing the oxidative stress and causing structural or functional damage to the cellular components. Coming to the global temperature rise cause recurrent dehydrations, concentrated urine, high urinary supersaturation, in turn leading to stone disease, and their incidence rises after every heat wave. The climate model predicts that 1.6 to 2.2 million additional renal stone cases may come up by 2050 due to this global warming. So all this, we have actually had a quantum leap in the increased advanced equipments, research, and medication that have happened in the last decade. But what is their impact on the environment? We can see here, if a patient with renal stone disease has to undergo a procedure as simple as a ureteroscope, it releases 4.3 kgs of CO2 emissions per session. And any OT procedures with consumables, 87 kgs for a single use and 71 kgs for reuse of the consumables like drapes or gowns, whatever they are using. And robotic surgeries have increased a lot in the recent years. It is both patient friendly and doctor friendly, where the surgeon has has the ease of doing the surgery while sitting and in the comfort. But what is its impact on the environment? When we look at this robotic versus open surgeries, 40.3 kgs per session versus 22 kgs per session, there is almost double the rate of CO2 emission per session of per surgery. And imaging, we can see here that MRI releases around 17.5 to 22 kilograms, CT 9.2. The lowest is the ultrasound with 0.3 to 0.5 kgs of CO2 emission. So we need to focus and go back more to ultrasound first approach for renal stones rather than going for CT or MRI first. And in case any of this renal stone disease patient lands up in ESRD requiring hemodialysis, if we look at this data, carbon footprint for one single session of hemodialysis is 25 to 30 kgs. And an annual impact, if the patient comes thrice a week, is 4.2 tons. If we need to convert it to travel, look, driving a car for 150 kilometers or 1.5 trees working for a full year is what is required to neutralize this. So I think green dialysis is the next step where We need to reduce the dialysis by using incremental schedules. Incremental schedules. We
Arifa, can you mute others, please? Arifa?
Yes, ma'am.
Arpita madam, please mute your phone, madam.
So we need to support reuse, recycle of all the products that we use in dialysis. We need to reduce the water consumption and energy consumption and choose renewable energy over non-renewable energy. We need to introduce environmental impact criteria in the checklist while evaluating hemodialysis machines, triage the contaminated and non-contaminated material to be more planet friendly approach. As we have discussed, ultrasound first approach reduce the hospitalizations and to reduce the lower the healthcare footprints. So what community strategies that can be implemented, like how Shiva Parvati madam has gone into the community to educate common people on good nutrition, preventive programs in high risk regions, hydration campaigns in hot climates, climate adapted workplace policies should be implemented. We need to give access to safe drinking water and preventive strategies. So I would like to conclude with the actionable points that we can take. Protecting the kidney and the planet can go hand in hand, and we need to focus more on this. And by educating the patients with preventive strategies to prevent recurrence and thereby cutting down on the cost and resources, we need to give delayed, individualized and incremental dialysis to whoever possible CKD and ESRD patients, and encourage transplantation because it has a lower environmental adverse effect when compared to dialysis. So with this, I would like to conclude. Thank you, everyone. Any questions I would like to take?
Very nice, lucid presentation, Fanishri, on prevention of recurrent stone formation and its advanced treatments and its impact, the treatment's impact on the planet, our planet Earth. I request our chairpersons to comment. Hitaishi madam, Jikki madam.
That was a detailed talk on stone disease and its impact, treatment impact on planet.
Yes.
So topic is open for discussion.
Now, for the want of time, I believe I think we should move on to the next session. So before
Jikki madam.
Okay.
Jikki madam, you have a comment? I think. Okay, I think madam is not available, and very good work, Fanishri. And one announcement from AP chapter, we have conducted essay, and we are very excited with the alarming response. Till now, we have received 307 essays from all the MBBS, MD, and high school children. And we will be releasing the results on in SRNM Con, which is to be held at Hyderabad. And I request Swarnalata madam will, as we give the,
That's a good talk by Dr. Vanishri. You have covered not only the stone disease, but also about the green nephrology. I would just like to know if any center has taken up a genetic analysis study of the calculus disease. I mean, in our India, if any center has taken up.
Swarnalata madam.
Madam, I don't think we'd first do a metabolic workup for the stone. If it is negative and there's a strong family history or recurrent stones, probably we can do a genetic studies, particularly with respect to our oxalosis and all those things. In general,
Yes,
adult urologically patient women going for single stones, they're not doing a genetic workup. I think they are deferred to nephrology, and as a nephrologist, First we do a metabolic workup followed by a genetic if at all is required, but not as a protocol, I believe.
So,
Yes,
madam, I
ma'am.
would like
In
to
pediatrics, I
add
think we
here.
have a paper
Yeah,
from
yeah. So
Ames
sorry,
Delhi.
sorry. So same thing
Sorry.
I was just about to tell. Like we also have a lot of pediatric load, and we have done genetic work for pediatric stone disease, but most of it associated with CACUT also. So we have varieties. I mean, mostly we used to think it's because of CACUT and obstruction and all, but metabolic causes are common as well, especially in those who have a family history. So apart from oxalosis, which we all know, cystinuria, then even the mutations of this CASR. So that and even magnesium and phosphate related disorders. So we had one case of hereditary hypophosphatemia with hypercalciuria. So such patients again, I mean, and I think we have sent a case report for publication. So genetic workup, though not extensive because it's very expensive. So after doing a metabolic workup, as Swandata said, for patients with family history or likely metabolic disease, we have done a genetic workup. But again, the numbers are limited. Still, this thing is continuing. Thank you.
Okay.
Yes, ma'am.
After completion of Andhra Pradesh chapter, we will be handing over the stage to Karnataka chapter. Dr. Spurti will be the moderator.
Now, before Karnataka takes over, request all the state chapters to please restrict themselves to the time because we have
Yeah,
8 published chapters and each chapter takes on 10-15 minutes time. It will be another 1.5 hours. So I think I request all of you to please stick on to the time.
Yeah.
Tight
Yes,
schedule.
Purti, please. You can.
Dr. Spurti, are you there? Deepti, are you from Karnataka?
There, I believe she's there, but I'm not sure. Spurti, I'm able to see you.
Deepti is from Pondicherry.
Okay. Spurti, please take over. Spurti, you are on mute.
We
You are
came
not
having
audible.
very early lunch because it's starting at 1 p.m.
Yeah.
Spurti, you're not audible. You have to unmute yourself. Still, you're not audible.
Spurti, you are not audible, Spurti. You can increase your volume.
Otherwise, you can ask your co-host to co-chairman to take over. Meanwhile, you can work on your audio.
Good afternoon, ma'am. I'm Dr. Pooja here.
Yeah, please.
Good afternoon, everyone. On this occasion of World Kidney Day, I extend a heartfelt welcome on behalf of WIN Karnataka. I'm Dr. Pooja Prakash Prabhu, Associate Professor, Ramaya Medical College. Sorry for the technical glitch. I think Spurti will sort it out in the meanwhile. So I would like to briefly tell about WIN Karnataka. Would briefly like to highlight our achievements and commitment towards encouraging women in the field of nephrology. WIN Karnataka chapter was formally inaugurated in September 2022. The chapter aimed at emboldening
You have
the
any
core values.
visuals, slides?
Uh,
No.
no, ma'am.
Okay,
I
please
just
carry on.
thought a brief discussion. Yeah, so I just kept it
Please carry
plain. So this chapter was started to embolden all our WIN values at regional level. Under the patronship of the mother of nephrology in Karnataka, Dr. Akmaha Devi Madam, and under able leadership of all our senior nephrologists, Dr. Renuka Madam, Dr. Anupama, Dr. Anita, Tapoti Madam, Dr. Leelavati, we at WIN have been able to spread our wings far and wide. Women nephrologists are now not only in the capital city, but also they have reached all the peripheral districts of Karnataka, like Udupi, Gulbarga, Hubli, Bijapur. They have been doing excellent job in nephrology. We are also active in interventional nephrology. Myself and Dr. Purnima in Gulbarga, who've been active in this field. Pediatric nephrology has also gained a great momentum, and they are a part of our team. And this year, ISPN Con is being conducted at Bangalore, and our WIN pediatric nephrologists are very enthusiastic about it. We have several women nephropathologists who are also in our WIN Karnataka chapter. They are contributing equally to the growth of WIN Karnataka. We do meet regularly and have a healthy discussion on both professional and personal fronts. The Women's Day celebration that was held had a very good response, a meet and greet, and also the guidance given by the seniors to the juniors as well as the postgraduates was very well appreciated. The WIN Karnataka also actively participated in the WIN Icon that was held in Chennai and brought laurels to the state. There was a great WIN representation at the recently conducted Southern Chapter, that is ISN Southern Chapter conference at Hubli, and many were invited as speakers and chairpersons. So finally, Women in Nephrology Karnataka chapter, we are a close-knit unit, striving hard, passionate doctors, compassionate healthcare providers, able homemakers, daughters, trying to give their best back to their society, which has enabled them to become wonderful citizens of this country. So with this, I would like to ask Spurti to take over and present our World Kidney Day celebrations that was held across Karnataka. Thank you.
Yes, Purti, you are ready? If still not
Purti,
ready, probably we
you are
can
not
go to Christine.
Christine, can you start your presentation, protein supplements and kidney health?
Hello. Yeah, hello. Yes, I'll start then. Okay.
Yes.
Just a
And
second.
your chairperson, Saurabha, are you ready? Dr. Saurabha.
Just a second.
Pooja, can you introduce Dr. Saurabha?
Yes, madam. I'm pleased to invite Dr. Saurabha Rajanna. She is an associate professor at St. John's Medical College. Dr. Saurabha, can you just join the WKD meet?
I have to share my screen. Can you enable sharing the screen? I think.
Arifa, are you there?
Yeah, I think I'm able to. Yeah, 1 second. Is my screen visible?
No, not yet.
Not yet. Okay. You okay, mine shows that, and 1 second, let me do it again.
Yes, ma'am, it's visible. Let's go on. It's visible, ma'am.
Are you able to see my screen?
Yeah, but I think you should share your slides. Yeah.
Yes.
Yeah.
Okay, should I start?
Yeah,
Yes.
so I would like to welcome Dr. Christine George. She is the consultant nephrologist at Astor Whitefield. She'll be talking to us about health supplements and kidney health. Over to you, Christine.
Thank you, Dr. Pooja. I think this is a very, very pertinent issue. Now, more and more patients come to us with this question, and many a times it's not easy to answer to their query. So, I'll try to shed some light on this common topic, that is health supplements and kidney health. So briefly, I think we have already seen the functions of kidney. In simple terms, they are filters which filter waste from the blood. But it is important to understand that kidneys are far more than simple filters. They are important to maintain the balance of water and minerals. Kidneys are the control centers for your blood pressure. Kidneys produce hormones for maintaining the hemoglobin and maintaining the right amount of red blood cells. Kidneys are important to maintain the bone health. So, kidneys are definitely filters of waste from your blood, but they also have other important functions. Now, when we talk about supplements in general, now we have people who are very health conscious, especially youngsters, and many are taking vitamins, including some herbal products and protein powders. There is a increasing trend of youngsters going to gym, trying to get bulked up or uh, get into this professional bodybuilding, and they often come to us already taking protein supplements, and they have found some variation in their blood values, or they want to ask before starting these supplements, and it is assumed that they are completely safe. In fact, a lot of gym instructors, friends, uh, groups, WhatsApp groups, they suggest how much to take, which brand to take. But it is important to remember that some supplements can in fact harm your kidneys, and the risk can be higher if taken without appropriate advice. So, what are some of the common supplements that people take? Vitamin supplements, protein powders. Protein powders can be low protein, high protein, or very high protein density powders. Herbal and traditional medicines. Again, a very common idea that people have is that herbal and traditional medicines have absolutely no side effect. Then there are people who take various bodybuilding supplements, including creatine supplements, to build muscle mass in a short period of time. Then there are people who are on weight loss or the so called detox products. Now, some of these supplements are known to have an effect on the kidney. For example, high dose vitamin C supplements, excessive vitamin D supplementation. We know, we have seen patients coming with very high calcium levels. Very high calcium, known as hypercalcemia itself, can cause kidney injury. Creatine supplements, again, uh, creatinine is a measurement which tells us the amount of filtration function that the kidneys are doing. So when somebody is on creatine supplement, the creatine will be broken down to give this byproduct, that is creatinine, which we are going to finally measure in the blood. So creatine supplement, if taken in excess, your blood reports may show the creatinine number to be high. Again, it may be high, but your kidneys may be functioning absolutely normal way. But also at the same time, if creatine taken in large quantity may have an effect on the kidney function long term. Again, certain herbal mixtures, the problem with the so-called traditional herbal or natural medicines is that the exact content, concentration, and the effects of these components have never been studied. So what I always tell my patient is that any medicine that we write from allopathy, we know exactly where it is going to act, and that is why we know the side effects. Now, the preparations, the so-called herbal preparations, has thousands of components, the effect of which has not been formally studied. Now, high protein supplements. When we talk about high protein supplement, we all need protein. The body undergoes normal wear and tear, and depending on your extent of physical activity, your age, your nutritional status, your body needs protein. What happens if you take protein in excess of what the body needs? What is important to remember, any amount of protein you take is going to break down, and the breakdown products are going to be filtered through the kidney. Now, during this phase, there is what we call as hyperfiltration. For example, those of us who eat non-vegetarian diet, after taking a high load of protein, the kidneys do function at a higher rate, and if you have noticed, the frequency of urination also increases. So basically the kidneys undergo what we call as hyperfiltration. The healthy kidney is able to do this, and without any consequence. Now, think of somebody who is taking high protein on a regular basis in excess of what the body needs. The kidney is hyperfiltering every day, multiple times, and in the long run, hyperfiltration is known to have effects, what we call as hyperfiltration injury. Now, another important thing to remember is just like how height and weight is a spectrum across the population, the number of filtering units that your kidney has, known as a nephron endowment, is also something decided at birth. Now, out of 100 people who are on protein supplement, 1 or 2 may be born with fewer number of nephrons. And if such a person also keeps pumping the kidney with high protein, in the long run, over years, the kidney is going to suffer injury, and they have a high risk of developing chronic kidney disease. Now, another aspect is regarding supplements. When we talk about protein, there are different ways of or different forms of protein supplement. Some of these are herbal, and herbal products, again, the problem is we don't know the exact content. Some of these herbal products may contain heavy metals. Ingredients are not clearly listed. Some herbs can directly damage the kidney. There are studies and data to show that certain herbs can directly injure your kidney and lead to chronic kidney disease, which can progress to end stage kidney disease, even requiring dialysis and transplant. Fourth important point is quality control may be poor. So herbal products, the manufacturing, same brand, same name, across 10 bottles, the content may be different. So there is poor quality control. So as I discussed, very high protein intake strains the kidney. When we call it strain, it is in technical terms, it is hyperfiltration that the kidneys have to undergo. It can worsen an existing kidney disease. So somebody may have an undiagnosed kidney disease, and when a large number of people in the population starts taking protein supplements, some of the susceptible people or individuals will develop kidney disease. And people with kidney disease definitely should avoid high protein supplements without proper prescription or consultation from your nephrologist. Now, some of the so-called alternative medicines or supplements may even contain hidden painkillers or sometimes steroid preparations. And again, when taken over a long period of time, these can damage the kidneys. So if somebody is taking these alternative forms of supplements, be always sure that you check the ingredients and you know what you are taking. Especially people with diabetes, people with high blood pressure, those who have kidney disease, definitely our kidney transplant recipients and elderly individuals should be extra careful. And I would add on to say that anybody who takes should be careful, because we all know that kidney diseases are completely silent, and we don't know how much is your kidney reserve. So if you are taking any of these supplements, be consciously aware that you should get your kidneys checked and consult your physician. Again, some of the warning signs of kidney problems, I'm sure we would have heard during the day, like swelling of feet, foamy urine, reduced urine output, fatigue, or high blood pressure. But again, we cannot rely on these signs to appear. We should proactively get uh, our kidneys checked, because kidneys are silent workers and they do not let us know when they are strained. Avoid unnecessary supplements. Do not exceed the recommended doses. Consult your doctor before taking any supplement. Drink plenty of water. Get your blood sugars and blood pressure under check. Kidneys are vital for health. Ask your doctor before taking supplements, and always use medicines and supplements responsibly. Thank you. I'll be happy to take questions if any.
Very lucid and nice presentation, Christina. This is the common problem we are facing. So many are taking creatine supplements and Herbalife products and getting with the AKIs. And you have covered all the things. And Pooja, can you comment?
Yeah, hello. Good afternoon. Christine, this was very apt for the current generation and current topic. We have seen patients expressing high financial constraints when it comes to getting treated with the kidney problem, but they don't mind spending a great amount of money on the products which come with no validity or no clear-cut guidelines. So this could still help us in of creating an awareness among the general public regarding the harmful effects that it can cause, certain irreversible damages that can happen not only to them but to their entire family that suffers due to the CKD that sets in later on. So thank you, Dr. Christine. If there are any questions from the audience, Dr. Swarnalata
Actually, I
ma'am.
have seen one patient on creatine supplement developed membranous nephropathy. Is there any literature, Christine?
Madam, I have not found creatine supplement and membranous nephropathy, because even I had couple of patients who came with elevated creatinine values while on creatine supplement. But like majority of them, when we do a cystatin GFR, it comes normal. But them developing any primary renal disease like membranous, I have not come across. Probably others can also share their views.
And in Andhra
Swarnalata,
and
madam.
Telangana, we are facing so many naturopathies like Veeramachinini, and they are giving so many oils and all. And Herbalife is also very rampant. They are forming groups in the small villages, and they are spreading the Herbalife usage like anything. And they are getting with the kidney injuries. And I have seen so many AKIs with this Herbalife. And so something from our community, we should give some guidelines to the public so that these supplements should not be used, and they should protect their kidneys from all these supplements. So,
Yeah, I think
madam,
great
your
talk.
comment?
Great talk, Christine. I think it's very important point to remember. Diet, as Saivani has said, there are a lot of different patterns of diet being available in the general what do you call. They are propagating their diet pattern, and most of the kidney patients, they come back to us, and not just AKI, even CKD patient. They go back and they use, and they come with a progression of the kidney disease. In fact, we have a lot of patients who are from Ayurvedic background. They themselves are using, and they are trying to promote within our own unit. So we are facing a lot of challenges. So we have to be very clear in our message that these products are very kidney not kidney friendly. So that message should be clear. And the second part is the protein supplementation. In fact, I'm a fitness freak, and I myself have a lot of what you call desire to use those things, particularly in this age where we are going through a process of menopause, and we need to have this protein and muscle being preserved because of sarcopenia and all those things. So there's a lot of temptation to use that, but I think you should be very caution in using all these products, and we should have proper knowledge and what is there in that product, protein products and whatever it is. So with awareness only, we should be use that.
So
thank
I would just like to add one point to what Dr. Swarnalata said. So whatever you say, these gym goers and bodybuilders are going to have, they will keep on taking supplements. So few important things are that we should still tell them that the total protein intake should be kept less than 1.6 to 1.8 gram per kg. That much can be allowed. That is one thing in gym goers and bodybuilders, not for everyone. And creatine supplements should not exceed 5 gram per day. This, again, you have to tell them, because whatever you do, they are bodybuilders. They need protein and adequate hydration, and tell them not to take supplements which are unregulated, because as Christine pointed out, like they have other things as well in addition to phosphorus. That also causes a lot of problems. And many of the times, like we get patients, youngsters, where creatinine values come high, but the kidney function is supplementation. So again, we have to stop, repeat the GFR, and use GFR by not creatinine-based methods. Nice talk. Thank you.
Vimala, madam, please mute your phone, madam.
Actually, I have an experience, madam. Already a dialysis patient went for the cure and he developed HUS. Severe HUS. Only after I did plasmapheresis for a week, that patient came out of the ventilator, and thrombocytopenia. So there are multiple variations. Like unless we publish these data, like Saivani madam said, membranous nephropathy, I have seen HUS. Some AKs are very common. They recover transiently after stopping if the exposure is in session. So I think we'll all try to publish the data, and it will be helpful for others also.
Yes, thank you, ma'am. I think that is the point, because we don't publish, we don't have evidence to tell that something causes something. When the patient comes with a doubt, we can only say that we do not have data to say it is safe. So that's what I tell my patients.
Yeah, 1 second. The government should have a regulatory body to give statutory warning on these health products, that they could produce some damage to the kidneys if taken inadvertently without supervision. Such things should be done. It is part of the government's responsibility also. to take up this.
Yes, ma'am.
Yes, madam, agreed. I think we should able to emphasize now that even this the paraquat poisoning now government has taken seriously. I think over a period of time, once we emphasize it repeatedly to the policy makers, it is doable, madam.
From Kerala, we have published the data on the face whitening cream containing lot of mercury,
Yes, ma'am.
producing NEL1 positive membranous nephropathy.
True.
Few young ladies coming with membranous nephropathy, and hence it was identified. And the product contained, it was an indigenous product without any specific brand or something, and contained lot of mercury in that. All were NEL1 positive. That was published in Kidney International.
Okay, shall we move on to the next? It was, I think, great discussion. Saivani, shall we move on to the next state?
Hello. Northeast and East.
Dr.
PRDs
Saivani, I think if there is a, madam, if there is time permitted, can we speak a few words for 5 minutes on World Kidney Day part
Yes,
of
please. If she
discussion?
is ready.
Spurti,
Hello, ma'am.
are you ready?
Yes, ma'am. Yes, ma'am. Can you hear me now, ma'am?
Yes, please.
Yes.
Yes,
Good
please go
afternoon,
ahead.
ma'am.
Thank you, ma'am.
I'll be sharing the screen from that, ma'am, regarding the World Kidney Day activities done by Karnataka chapter. I'll be sharing screen from a different because in this voice is not
Audio
audible.
was not. Yeah, I do come across such a challenge intermittently. So
vehicles from brands like Honda, Nissan, Subaru, and Hondas now rely heavily on CVTs. And
This is the are you able to see that, ma'am?
Yeah.
My screen? Yes, ma'am.
now it is
These
visible.
are
Yeah.
the activities conducted by Karnataka chapter. Uh, Dr. Ankita, consultant nephrology at Prakriya Hospital, Bangalore, conducted various interactive sessions on World Kidney Day. It started off with the kidney awareness and for entire hospital staff. They celebrated with a blue and green theme. They did an innovative skit with hospital employees playing roles of a patient delivering message about prevention, detection, and even about the kidney transplant. And there was also a kidney screening camp for police officers. They launched a kidney screening package, and there was also an innovative kidney booth to take pictures and
Spurti,
promote.
can you mute in one of the device? We are listening to two voices from you.
Yeah, there is resounding happening, so you can actually
Resounding.
mute one of the devices.
You mute
Sure,
one
ma'am.
of them.
many drivers today experience trouble for years. Are they perfect? Not quite. Nothing in automotive engineering truly is.
Hello?
You are audible.
Yes, ma'am.
Yes, please carry on.
Smriti, just can you go back? I think things were not very clear at that point.
I think no issue. We can proceed with this.
Okay, ma'am.
Yes, ma'am. Dr. Swara, consultant, had conducted CKD awareness program at Aveksha Hospital in association with Nephroplus. There was a large gathering and awareness program, which was an eye-opener. And there was also a free health camp, which was held at Adarsha Hospital, Udupi, by Dr. Megha Pai. Dr. Garima Agarwal Manipal Hospitals organized various World Kidney Day activities, and summer is here and the fluid restriction is a must. Ma'am distributed 500 ml water bottles to all patients as a goodwill gesture and as a reminder to stick to fluid limits. They also organized CMS where nephrologists spoke to other specialty doctors about how to recognize kidney disease early and also for early referral. They organized a photo booth in busy OPD waiting area, but the specialty of this was there was a QR code which on scanning will help to recognize patients who are at risk for kidney disease by answering a few simple questions. Dr. Anika ma'am has been very creative. Ma'am has spread awareness among people by writing a post that is Kidneys Ki Man Ki Baat. The kidneys have themselves what affects them and how to protect them. Even children can
Others,
easily
please
understand
mute yourself.
kidneys' role in our body and also the risk factors and Dr. Pooja ma'am of Ramaya Hospital has organized variety of activities and she has spread awareness with post-mortality transplant and a successful paired kidney transplant by using a skit where PGs have played the role and they have successfully shown the swab transplant. And there were also various activities which were conducted throughout Karnataka, and these were the glimpse of few of them. Thank you. This is a skit showing paired kidney transplant, which was conducted in Ramaya Hospital. And this is what I told regarding Man Ki Baat, where the kidneys have spoken themselves and given an interview. Thank you.
Thank you, Spurti. I think that was wonderful and covered all the aspects by all the areas of Karnataka. So good job done. So can we move on to the other state, please, if there are no comments from Karnataka?
Thank you, madam. Thank you for this opportunity. On behalf of the president, Dr. Renuka ma'am, she couldn't join today, and our secretary, Dr. Maitri, both of them couldn't make it. So we try to organize.
No
this.
problem. You well done, both of you. And though the president, secretary are not there, I think you had well done. Though we had initial technical glitches, but I think overall the program was good.
Yeah, thank you.
So,
ma'am.
Saivani, can we ask, East and Northeast?
East and Northeast, yes, madam. Piyali, are you ready, Piyali?
Yes, ma'am. I'm ready.
Yeah.
But once again, I request to be on time, please, because even 10 minutes time will be 1.5 hour delay.
Yeah, sure. So, on behalf of East and Northeast, we extend our greetings to all the members of the Women in Nephrology team. And I would like to congratulate at the outset Dr. Manisha Sahai, Dr. Swarnalata, and Dr. Saivani for organizing such a beautiful program. And it has been, I also participated in the WIN program, international program yesterday. It was well organized, and kudos to the WIN team. Now, actually, we have two presentations, and our chairperson is Dr. Arpita Rajchaudhary, who needs no introduction. So she is the chairperson of the Indian Society of Organ Transplantation, and also is a very active member of the West Bengal chapter of Women in Nephrology. And she has been a force to reckon with, and she inspires all the junior colleagues, to participate and to do all the. So right now I will share the. So is it visible? Is it visible, ma'am?
Yes, it's visible. It's visible. Please go ahead.
So there were multiple programs which are held in the state of West Bengal regarding women and to celebrate the World Kidney Day in 2026. And these were some of the programs that were organized. That is, one of the program was done by Dr. Pooja Banerjee, and she organized a program to promote patient care with to the technicians. It was about green nephrology, and she was the speaker there, and the chairperson was Dr. Arpita Rai Chaudhary. Again, another of our young nephrologists, that is Miss Dr. Ramita Sarkar. She organized a program on waterborne infections in the dialysis units, suspect, confirm, and save your patients. And it was chaired by the other nephrologists like Dr. Sharmila Chukal, Dr. Orko Majumdar, Manish Jain. And Dr. Pallavi Mahato, she did a program on home hemodialysis options. It's time to promote more. And it was chaired by the other nephrologists like Dr. Upal Shandgupta, Dr. Shaugato Dasgupta. And again, Dr. Kiti Sarkar, another young budding nephrologist from West Bengal. So she spoke on green nephrology, and it was chaired by Dr. Pratik Das, Dr. Smarta Pillai, Dr. Shusri Das. So this was one of the programs. So now to play a little bit from the program from Dr.
Can you make it slideshow mode, Piali?
Start very early detection. When we fail, they reach dialysis. We should promote transplantation. The dialysis should be done in a way that it is most eco-friendly. There is energy optimization, less greenhouse gas emission, more protecting the planet, less water consumption. And we know the home dialysis system, PD and home hemo both. Home hemo costlier option for LMICs. So promoting PD more, home dialysis becomes more eco-friendly and energy efficient. So
there was another program which was held, and this program was, the topic was to prevent CKD progression, a detailed diet plan. And the speaker was Miss Vijay Agarwal. So these were all dietitians of different hospitals in the West Bengal. So the speaker was Miss Vijay Agarwal. And there was another session on CKD patients and dialysis diet making more palatable. And it was also done by another nutritionist, that is Miss Padmaja Nandi Malik. And there was a session on cardio kidney metabolic patients, time to cut down your obesity. That was done by another nutritionist, that is Miss Babita Hazarika. And the fourth one was hepatokidney metabolic patients, diet and metabolic syndrome. And the speaker was Momita Raichaudhary, who's also known to be a good nutritionist in Kolkata. So to take a glimpse of that program, ma'am.
I should introduce the concept and theme behind this. This is the initiative being asked by our own Arpita ma'am.
So good evening, Dr. Tiwari and his 10 members. I am very happy that you have accepted my proposal of doing a joint program to sensitize both our nutritionists and reach the patient's kitchen to today's talk and sensitization. Let me introduce my representation today. I am representing today women in nephrology.
Let me share the topic as you have mentioned. That first topic will be going to do with the to prevent the CKD progression, a detailed diet plan. Along with me, the session will be chaired by Dr. Arpita Raichaudhary and Ms. V. Champa Majumdar. Dr. Vijaya is the Chief Dietitian in Manipal Hospital, Dakuria, Kolkata. Please start.
Yeah, thank you, Dr. Indrajit Tiwari and Professor Arpita Raichaudhary for giving me this opportunity to talk something about CKD diet. Basically, as you all know, dietitian plays a very vital role.
So now moving on to some of the programs that were organized by ESI Hospital Manikpala. So just to say a little bit about ESI Hospital, ESI stands for Employee State Institution. And so it is an institution in which there's a program of, healthcare, in which a part of it is contributed by the patients themselves, a part of it is contributed by the industry in which they work, a part of it is contributed by the state, and a part of it is contributed by the center. So it is a robust scheme, and it it caters to about 1 crore population in the state of West Bengal. And we being a part of the ESI Hospital Manikpala, we had tried to do something on World Kidney Day. And so these were the few of our activities which were held at our hospital. And so this is ESI Hospital Manikpala, and so it is a 50-year-old institution. And we had early in the morning at 6:30, we had organized a marathon with all the healthcare workers, the students, doctors, nurses, and anyone who was happy to join. So we organized a marathon for them at 6:30 in the morning. It was a marathon which was led for 5 kilometers, and was enthusiastically participated, and the prizes were distributed for the winners. So these are the trainee nurses. An ambulance accompanied the people participating in the marathon. The whole thing was supervised by the Kolkata police, and this is a person who came first in the marathon. So he's one of the doctors of our unit who has also participated and won a prize. This is one of our dialysis technicians, and she has also won a prize amongst the women category. This is one of the GDA general duty attendant of our hospital, and he has also enthusiastically participated and won a prize. So we also had our chief, nursing staff. She's 61 years of age, and she participated enthusiastically in this marathon, and she also won a prize. So next, our next program was, planting of these tree saplings, and this is in view of the protecting the planet aspect of it. And we planted a lot of trees in our hospital as well as in the nursing training center. And so this is to the reduce, to absorb some of the carbon footprints that we are emitting. And also we had a program later on in the day in which the deputy director, he promised us that the RO water, the extra RO water that we have, that will be utilized for watering the gardens. So that was one of the positive steps that was taken. So he's one of the doctors who work in our unit, and they all very enthusiastically participated in the World Kidney Day program from 6 o'clock in the morning, which was carried out till later in the day. So this is in the nurses training center, and she's the nursing superintendent. This is a sister in charge in the dialysis unit, and she also participated in the marathon and won a prize. She's 61 years of age. He is a doctor in our unit, and he has also won a prize in the marathon. And this is the second program that was held in our hospital on that day, and everyone enthusiastically participated in planting the trees. Now that there was a third program in which we tried to spread awareness regarding the kidney diseases and what we can do about it for the preventive modes that we can initiate, so that in order to prevent kidney diseases in our state.
मुझे डायरी और वो पेन पेन देना।
So this is the superintendent of the hospital. And just to bring it in context, the superintendent of the ESI, so ESI Hospital Maniktala, it is the main unit, and we have 13 satellite units in the state of West Bengal, which caters to, as I said, about 1 crore population. And the superintendent has very kindly agreed that healthcare checkup will be held in all the 13 ESI hospitals. He had promised in this very program that healthcare checkup, including the blood pressure checkup, blood sugar checkup, as well as the checkup of all kidney function tests. That is some simple blood tests, urine tests, and ultrasonography will be done for all patients. This decades of life early detection অনেকটাই এটা প্রিভেন্টিভ করা যায়। তো আমরা প্রপোজ অনেক জায়গাতে করেছি, আমরা বলছি কখনো কখনো ফল পাই স্কুল লেভেলে যদি স্ক্রিনিং করা হয়, বাচ্চাদের যেমন 8, 9, 10, 11, 12 বাচ্চাদের কিছু একটা যদি ইনজিনিয়ার থাকবে যদি একবার টেস্ট করে দেখে নেওয়া কেউ সাফার করছে না, আমি তো আমি ঠিক আছে, তারা এখন কিন্তু বুঝতে পারবে না, কিন্তু আমরা তো এইসব জিনিসগুলো আমাদের আইডিয়াস গুলো আমাদের মধ্যে এটা আমাদের ভাবি অনেক কিছু করবো ভাবি বেশি খালি করে নিতে পারি না, কিন্তু আমাদের তো আর খুবই ক্ষমতা করার তো এই জিনিসটা মানুষের শরীরে প্রথম ইন্টেলিজেন্ট অর্গান হচ্ছে মাথা, সেকেন্ড ইন্টেলিজেন্ট অর্গান, সেকেন্ড মোস্ট ইন্টেলিজেন্ট। কেন গুরুত্বটা কেন কেন আমরা আমি আমাদের শরীরে লক্ষ রকম মানে শরীরের কারণ আমরা ইমিউন থাকতে ইমিউনিটি পাওয়ার কম, ওটাই খুঁজে রেখে দিলেন, ওটাকে কেন always every So this is the deputy director of the ESIMB scheme, and he has also, very generously promised us that the screening program that we talked about will be held out in all the 13 branches of the ESI hospital in different parts of West Bengal, and I think a lot of people will be benefited by that. So these are some of the things that were held in for ESI hospital, and I would ask Dr. Arpita Roy Chaudhary to speak something for this occasion.
Madam is there? I don't think madam is seen. So, okay, okay. I mean, shall we move on to the next state if madam is not there? I think it was good activities were done. In fact, the smaller steps like, utilizing the reject water for plantation and, the free health checkups for in all the ASAs. These are smaller steps, but I think it will go a long way in future. So good programs done. And I think this should be taken as one of the opportunity to influence or probably politicize our issues, particularly with respect to nephrology and dialysis care. and you have taken it right to the policy makers and got few, I think, steps are taken. Thank you, Piali.
Gayatri madam, do you want to speak anything from East and Northeast? Gayatri?
I think
Yes,
she's.
ma'am, I can.
Yeah, please.
Just a moment, ma'am. Two of my devices are working. Let me switch on off one my device. I am. Please stop this device now. Ma'am, thank you for the opportunity. I'm audible?
Yeah,
Yes,
you are audible, ma'am.
Okay, thank you,
Piali,
ma'am.
can you please stop sharing? Or it's there in the same presentation?
No, it's a different presentation, ma'am.
Okay. Then
So
Piali should stop sharing.
I will share a video where we'll be showcasing all the activities that we have done from the Northeast region. So basically, we have got 12 women nephrologists from complying in Northeast only. Most of them are from Assam, but we have got one from Meghalaya and one from Arunachal. So all of us are doing our bit to increase the awareness regarding kidney disease in this part of the country. As you all know that Northeast is a difficult terrain. It's comprises of hills and it comprises of valleys and rivers, and most of these rivers during the monsoon period overflows and it creates a lot of problem for the health sector. Luckily our chief minister is very much enthusiastic about healthcare. Earlier he was the health minister, so he is keen in opening new medical colleges. And today also I got stuck in a traffic because the health home minister has come for a meeting and inauguration of a new medical college, so we had to be present there, all of us. So I got a bit late. Anyways, so we are trying our bit on the occasion of World Kidney Day. Most of us, we are doing from our bit. We tried to create awareness about the kidney diseases by doing walkathons, by doing health camps, and by going into the social print media and as well as the in the print media. Then this time we went to a village called Rampur, around 200 kilometers from Guwahati, where we tried to create awareness regarding the disease, and also we did checkups. We did screening of people, and usually what we do is that on every weekend before the World Kidney Day, we are doing it from the last 4 or 5 years. We are trying to screen the population, from the population about kidney disease. So we used to collect the blood samples and then used to in our labs we used to see for the reports creatinine, for albuminuria, and then we do a bit of screening. So probably very soon we are going to present our data. And apart from that, we conduct walkathon from our hospital. And also we try to reach to the celebrities, because whenever a celebrity is involved, the awareness reaches to a different level. So we feel that involving a celebrity will help. So these are the few things that also we ask our fellow nephrologist, women nephrologist, to raise awareness about the disease in the print media or in the TV, so that they give messages about the disease. So I will just present a short video where we'll showcase all the things that we have done for this year. And I'm going to upload the let me share the video. I hope just a moment. Just a moment. Yeah.
On World Kidney Day, the world comes together for a healthier future. This year's message: kidney health for all, caring for people, protecting the planet. Across India, awareness is growing to protect kidney health and promote early prevention. In the heart of Assam, communities unite to spread this important message. Kidney disease affects millions globally, often silently and without warning. Promoting kidney health means advocating for early detection, equitable access to care. On the occasion of World Kidney Disease Day 2026, women in nephrology from the East and Northeast regions of India participated in various programs and awareness-raising activities under the powerful theme: kidney health for all, caring for people, and protecting the planet. As this year's message is a call to action for individuals and support for those affected. At the same time, we must acknowledge that environmental factors, such as clean water, air quality, and sustainable food systems, play a crucial role in preventing kidney disease and supporting overall well-being.
Dr. Manjuri Sharma, Professor, Department of
So those were the activities which were done. So we had a dietitian also involved, and who described about the various diets that were to be taken in a kidney patients. Now we are I'll be presenting a few messages which were given by our women in nephrology, starting with Dr. Manjuri Sharma ma'am. She is the HOD in Guwahati Medical College in the department of nephrology.
Guwahati Medical College. আৰু মোৰ এই ডিপাৰ্টমেণ্টটোৰ প্ৰথম মই জইন কৰিছিলোঁ 1995 1995ৰ পৰা আজি 2026 চনলৈ মই কিডনী বেমাৰীসকল চাই আছোঁ, কিডনী বেমাৰী চিকিৎসা কৰি আছোঁ, আৰু নতুন নতুন আমাৰ যিখিনি চিকিৎসা কৰিব লাগে সেইখিনি আমি কৰি আহিছোঁ। এতিয়া দেখা গৈছে যে আমি কিডনী বেমাৰীৰ সংখ্যা দিনে দিনে বাঢ়ি বাঢ়ি গৈ আছে। যদি বোলে আমি ক'বলৈ যাওঁ যে 2000 একেবাৰে আৰম্ভণিতে 2000 পৰা 2010লৈকে আমাৰ কিডনী বেমাৰীৰ সংখ্যা ইমান বাঢ়া নাছিল, কিন্তু কিডনী বেমাৰীৰ সংখ্যা ইমানকে বাঢ়ি গৈছে। গতিকে কিহৰ কাৰণে বাঢ়িছে আমি সেইখিনি জানিব লাগে। দেখা গৈছে আমাৰ অসমতো বিশ্বৰ বাকী দেশবিলাকৰ নিচিনাকে ডায়েবেটিছ হৈছে নম্বৰ 1 কজ অফ কিডনী ফেইলিয়াৰ, আৰু নম্বৰ 2 কজ হৈছে হাই ব্লাড প্ৰেছাৰ। আমি ঠিক তেনেকুৱাই ৰোগী পাই আছো, কিন্তু এইখিনি ক'লে আচলতে আমাৰ দায়িত্ব সামৰা নহ'ব। আমি এতিয়া প্ৰত্যেক বছৰে মাৰ্চ মাহৰ দ্বিতীয়টো বৃহস্পতিবাৰে ৱৰ্ল্ড কিডনী ডে উদযাপন কৰোঁ, আৰু এইবাৰো আমি আজি 12 তাৰিখে এই ৱৰ্ল্ড কিডনী ডেটো উদযাপন কৰিছোঁ। ইয়াৰ মেইন এইম হৈছে যে আমি জনসাধাৰণক আমাৰ কিডনী বেমাৰৰ যিখিনি চাইনছ এণ্ড চিমটমছ থাকে সেইখিনি আমি অৱগত কৰিবলৈ এৱেৰনেছ এটা আনিব লাগে। কাৰণ আপোনাৰ কিডনী বেমাৰ হ'লে মেনি এ টাইমছ আপুনি আমাৰ কিডনী বেমাৰ যে হৈ আছে গমেই নাপায় যেতিয়ালৈকে আপোনাৰ কিডনী দুটা 50% ডেমেজ হৈ নাযায়। গতিকে আমি আৰম্ভণিৰ পৰা জানিব লাগিব আমাৰ কিডনী বেমাৰৰ কাৰণবোৰ কি। আৰু আমাৰ কিডনী ট্ৰান্সপ্লান্ট পেচেণ্ট আছে যথেষ্টখিনি আছে, আমি ৰেগুলাৰ কিডনী ট্ৰান্সপ্লান্ট কৰোঁ।
So we tried to convey the messages. Messages were taken from the different nephrologists, and we tried to percolate it down to the public so that they can learn more about the kidney diseases and can take precautions for the same.
I would like to have a sincere message that we should take care of our kidney. Amar duta bikro ase aru ei imaging organor amar care loato dorkari. We have to follow simple 8 steps or 8 golden rules to take care of our kidney. We have to do exercise regularly, at least 150 minutes of exercise in a week, both cardio as well as weight bearing exercises. We should not smoke. We should not take any alcohol regularly. Even in elderly patients, it is recommended that we should get our kidneys checked at least on an yearly basis to see. With the number of CKD patients increasing
in such a large scale, it is necessary that we should take the proper step as early as possible so that it's prevent the progression of kidney disease and take care of our health. Thank you.
Namaskar. I'm Dr. Miranda Pegu. I work at Guwahati Medical College and Hospital. On the occasion of World Kidney Day, I would like to remind everyone that our kidneys are working silently to make our body fit and healthy. Our kidneys to remove toxins. It regulates our blood pressure. It maintains electrolyte and fluid balance. It has also many other vital functions. Unfortunately, most of the kidney diseases are silent. So many of the patients, when they come to us, they present with a very advanced stage of kidney failure. That means kidney disease, they remain silent for a very long period. The good news is that kidney disease can be prevented by doing and following certain 8 golden rules. One of the golden rules are keeping fit and healthy. If you have blood sugar, control the blood sugar. If you have blood pressure, control the blood pressure. Avoid unnecessary painkillers. If you are smoking, quit smoking at the earliest. And drink adequate amount of water. So these are the few ways by which you can protect your kidneys. So this year theme for World Kidney Day is caring for the people and protecting the planet. This means that we really need to care for the people. At the same time, we also need to protect the planet. That means we need to care for the people by having a sustainable practices so that we can have a healthier planet for healthier people. Thank you.
Namaskar. My Dr. Bob.
Amount of water.
We also tried to take messages from our lab in charge. She is Dr. Bobby Das. She is a lab in charge. We have in the department of nephrology, Guwahati Medical College, where she gave a brief a talk about what are the various tests which we are doing in our lab and how we are carrying this lab and how we are giving the report within the same day of when the tests were done. Then other than that, we were
নিয়ন্ত্ৰণত ৰাখিবলৈ যিসমূহ টেষ্টৰ দৰকাৰ হয় সেই গোটেইখিনি ইয়াত নিয়মীয়াভাৱে কৰা হয়
Dr. Farham, consultant nephrologist. On this occasion of World Kidney Day, my message to all is very simple. Take adequate care of your kidneys by controlling your blood sugar levels, by monitoring your BP, blood pressure regularly, by keeping yourself hydrated, take adequate drinking water, avoid painkillers, processed food, junk food. Remember, kidney disease may remain silent until late stage. So, on this occasion of World Kidney Day, my request to each one of you is to get yourself tested so that we can detect any form of kidney disease at an early stage. Take care of your kidneys today so that you can live healthy. Thank you.
Hello, everyone. Myself, Dr. Tanurika Halarika, consultant nephrologist and renal transplant physician working in Guwahati. This year, World Kidney Day theme is caring for people and protecting the planet. So caring for people, it ensures equitable access to early tests, accurate diagnosis, and appropriate treatment for kidney diseases, especially for the vulnerable and remote populations. And protecting the planet, it recognizes how environmental factors such as extreme heats, air pollution, and unsafe water impact the kidney health. So, to keep ourselves healthy and the planet, protect our planet, we should take plenty of waters and we should keep ourselves hydrated, avoid dehydrations, avoid over-the-counter painkillers, avoid junk foods, and take a healthy meal. Thank you.
মই ডক্টৰ স্মৃতি কাকতি এগৰাকী nephrologist. On the occasion of World Kidney Day, যোনটো আমি প্ৰতি বছৰে মাৰ্চ মাহত চেলিব্ৰেট কৰোঁ, মানুহৰ মাজত বৃক্ষৰোগৰ বিষয়ে সজাগতা আনিবলৈ দুটা টপিকত হাইলাইট কৰিব বিচাৰিম। প্ৰথমটো বৃক্ষৰোগৰ লক্ষণসমূহ। পেচাব জড়িত যিকোনো সমস্যা, যদি পেচাবৰ পৰিমাণ কমিছে বা ৰাতি ঘনাই হৈছে, জ্বলা পোৰা হৈছে, ভৰি হাত ফুলা বা মুখমণ্ডলখন ফুলি যোৱা, উশাহ নিশাহৰ অসুবিধা, খাবলৈ মন নোযোৱা বা বমিৰ ভাৱ হোৱা বা ভ্ৰম বসাও কেতিয়াবা কিডনী ৰোগৰ লক্ষণ হ'ব পাৰে। তিনিটা বেসিক টেষ্ট যোনটো ইজিলি এভেইলেবল আৰু যাৰ থ্ৰুদি আমি কিডনীৰ বেসিক হেল্থৰ বিষয়ে গম পাব পাৰোঁ। তিনিটা পৰীক্ষা হৈছে সেৰম ক্ৰিয়েটিনিন, যোনটো ব্লাডত কৰা হয়, ৰুটিন এক্সামিনেশ্যন অফ দ্য ইউৰিন এণ্ড আল্ট্ৰাছাউণ্ড ইন দ্য কিডনিজ। যদিহে আপোনাৰ এই লক্ষণসমূহ আছে বা আপোনাৰ কিছুমান ৰিস্ক ফেক্টৰ্ছ আছে লাইক ডায়েবেটিছ বা উচ্চ ৰক্তচাপ বা ফেমিলি হিষ্ট্ৰী অফ কিডনি ডিজিজ, তেতিয়া এটলিষ্ট আপুনি এইকেইটা পৰীক্ষা কৰি নিজৰ কিডনি হেল্থটোৰ বিষয়ে জানিব পাৰে।
নমস্কাৰ, মই ডক্টৰ অৰুণিমা মহন্ত, বৃক্ক বিশেষজ্ঞ, নাৰায়ণ ছুপাৰ স্পেচিয়েলিটি হস্পিটেল, গুৱাহাটী। বৃক্ক আমাৰ শৰীৰৰ এটা গুৰুত্বপূৰ্ণ অংগ হয়, কিন্তু আজি বহুত দুখজনক বিষয়, গোটেই বিশ্বজুৰি প্ৰায় 850 বিলিয়ন মানুহৰ বৃক্ক ৰোগত ভুগি আছে। প্ৰত্যেক 10জন মানুহৰ ভিতৰত এজন মানুহৰ বৃক্ক ৰোগ আছে, কিন্তু অধিকাংশ মানুহে এই ৰোগ থকা বুলি গমেই নাপায়, কাৰণ এই বৃক্কৰ ৰোগৰ প্ৰাৰম্ভিক অৱস্থাত একো লক্ষণে নাথাকে। সেইবাবে আমি আগতীয়া চিনাক্তকৰণ কৰাটো বহুত দৰকাৰী হৈ পৰিছে। প্ৰত্যেক মানুহে 40 বছৰ পাৰ হৈ গ'লে বছৰেকে এবাৰ হ'লেও বৃক্ক পৰীক্ষা কৰিব লাগে। আমাৰ বৃক্ক স্বাস্থ্য ৰক্ষা কৰাটো আমাৰ সকলোৰে কৰ্তব্য হৈ পৰিছে। আমাৰ বৃক্কৰ স্বাস্থ্য বজাই ৰাখিবৰ কাৰণে কিছুমান সহজ
Gayatri, we are all short of time. Can you?
Yeah, ma'am. We're just about to finish the video. So basically, what we did was that we took messages from all our fellow nephrologists, and then we circulated them among the print and the social media, and so that there is more awareness regarding this disease. And I'll just stop sharing the video. Yeah.
Yeah, very nice moment from East and Northeast. And Gayatri, it's a very good job, and the video was very good. And the language we didn't understand, no? That's what.
Sorry, I can understand. And actually,
Yeah.
we wanted to pass on the message to general public also. So that's why we took in our local vernacular languages.
Yeah. It's good. Arpita madam, you have a comment, madam?
Actually, I'm not able to see madam here. I think that's a great
madam.
job.
Madam is present, madam. Madam, please unmute your phone, madam. Arpita, madam.
Yeah, I can see her. Madam, you are there. Your final comments, please.
Arpita, madam, please unmute yourself, madam. Yeah.
Hello, am I audible?
Yes, madam. Yes, madam.
Yes, ma'am.
Yes, ma'am, you're audible.
Am I audible? Yeah.
Yes, ma'am, you're audible.
Hello. Yes. The one-line message that goes for World Kidney Day, this time celebrated by WIN Nephrology, is multiple programs that has been done in a very coordinated fashion to reflect the actual action point, what we need to take in our daily life, what we do in our hospital, what we do after coming back in our regular practice, all need to be changed and fall in line with planet protection, health protection, as well as kidney protection. Thank you, Shanlata. I think most of us are the same opinion and we'll be observing it in our daily life.
Thank you, madam. The one good thing about East and Northeast is everybody are doing good job, but they project it very nicely. You could see that, very compiled.
Madam, the videos are very nice. Gayatri Pegu did a lot of work, and Piyali Sarkar madam also did a lot of work.
Yeah.
Thank you, ma'am.
We'll move on to the Kerala chapter now. Sajmi Shaji.
Thank you.
Yeah, I'm there. Am I audible?
Yeah, you are audible.
It gives me immense pleasure to welcome everyone to the WKD 2026 online session.
Stop sharing your screen.
Kerala chapter. Kerala has always been forefront in all the academic activities of WIN, and today we will be discussing a session on how to slow down the silent epidemic of chronic kidney disease, and we will also be discussing on the WKD activities from Kerala. We have as speakers Dr. Jyotipriya, consultant nephrologist, Muthoot Medical Mission, and Dr. Deepa KP, Consultant Nephrologist, Assisia Medical College, and Dr. Ambili, Assistant Professor of Nephrology, Amrita Institute of Medical Science, and Dr. Vimala A, Senior Nephrologist, Cosmopolitan Hospital, and Dr. M. Srilata, former HOD Department of Nephrology, Government Medical College, Kannur, and Dr. Gomati S, Professor and HOD Department of Nephrology Medical College, Alappuzha, will join as chairperson. Over to you, Dr. Jyoti Priya.
Thank you, Dr. Sajmi, for that kind words of introduction. So is my screen visible?
Yes, please, it's visible, but not in slideshow mode.
Make it into slideshow.
Yeah, it is right now?
It is now.
Yeah. Okay.
Continue.
Okay. So moving on to my topic, beat diabetes, protect kidney. So the stopping kidney failure must begin at the diabetes stage. So the first focus should be on to prevent diabetes through lifestyle and dietary interventions. India's biggest renal prevention opportunity is to stop diabetes. Now we know our country's growing crisis is the leading increasing number of diabetes, which is the leading cause of CKD. And India has one of the fastest growing diabetes populations, and CKD burden is rising silently. Now, the reality is many patients reach nephrologists at a later stage. Kidney damage would have already established, and the prevention window is thus missed. The delay in the diagnosis is the main culprit. Now, let me take your attention to few realities. The first reality is there is faster progression of diabetes to diabetic kidney disease in Indian population compared to Western population. Microvascular complications occurs earlier. Multiple system risk accumulates early. It was observed that Indians with type 2 diabetes develop microvascular complications much faster when compared to the Western population. Now, why this happens? I could say three main reasons for this situation. One, late diagnosis of diabetes. Two, poor early glycemic control. And third one, limited structured follow-up for diabetes care. Now, let's analyze each reasons one by one. Now, the late diagnosis of diabetes. Why is it happening? There is no structured national screening program. Testing often symptom-driven, and the large pool of undiagnosed diabetes is there. So what we are seeing as detected cases are just the tip of the iceberg. Now, the silent damage will be ongoing. Years of unnoticed hyperglycemia, kidney injury begins early, and screening can hence dramatically change outcomes. Now, there is something known as HbA1c gap. See, HbA1c is underutilized in routine screening and monitoring. Many patients are unaware of HbA1c. Still, our focus remains on FBS and PPBS. See, this is a survey, Dedicom survey, which has been conducted in Delhi diabetes community. The survey was conducted among urban diabetics from middle and high income groups, and only 13% of the respondents, 13% had undergone HbA1c testing, and only 21.7% had even heard of HbA1c testing. So lack of incorporation of HbA1c in a routine monitoring and screening is one of the important reason. And our usual practice is still to target FBS and PPBS. HbA1c can be grossly deranged even if FBS and PPBS are uncontrolled, as lunch or dinner is usually the largest meal among most Indians. And screening programs to detect diabetes are in a nascent stage in India. Now, what second reason? The golden years that is being missed. The first 5 years of diabetes is considered as the golden window, and diabetic remission itself is possible with lifestyle change in this period. Early control prevents lifelong complications. We know the concept of metabolic memory and legacy effect. Early glucose control leaving lasting protection. The epigenetic imprint protects the organs, and poor early control leads to persistent complication risk. And why this happening? Might be due to epigenetic changes, early hyperglycemia inducing DNA methylation, histone modification, microRNA activation, and these alter gene expression long term. And these are even transmitted across generations through gametes. And second reality which I want to highlight is something which we are not very familiar with, the Kerala paradox. See, the diabetes is rising among poor and also in rural population in our state. So the disease is no longer confined to affluent groups. Now, why this paradox? See, there is increased food security and calorie access. See, in Kerala, especially in rural area and among the poor population, they depend on public distribution system. So here you can see the rice is being supplied at a rate of 3 rupees per kilogram. So that much access to cereals is there. But the fact is, food items which are supplied through public distribution system at a subsidized rates are predominantly cereals. Pulses, vegetables, and fruits do not come under this. So there is a huge consumption of calorie and predisposition to diabetes. And second thing is the shift to sedentary occupations. Mostly this manual labor activity, the people from outside our states are doing, and physically less demanding office jobs are being taken up by the rural Keralites. And third thing, limited preventive screening awareness and delayed diagnosis. And also in rural areas, the reliance on the unqualified practitioners often delays the diagnosis and leads to poor glycemic control in the early phase of diabetes. And when these people develop CKD, the treatment becomes expensive and the poor population face the catastrophic cost. Now, the third reality is we have to focus beyond the sugar number. Now, the old model is chasing the glucose number, but now it is to be focusing on protecting the organs. The heart and kidney protection must begin early. See, in many settings, the general practitioners are the first contact for the diabetic control in the community. So we as nephrologists, the subgroup knows the first line should be, along with metformin, should be SGLT2 inhibitors, GLP-1 agonists. But how many of the general practitioners, how many of them are aware of the importance of starting the anti or oral hypoglycemic agents with therapy with these drugs? See, usually they focus on sugar numbers. Rather than focusing on diet and lifestyle changes, the focus is on lowering the numbers. Potent sulfonylureas, they lower glucose rapidly, both doctor and patient satisfied, but this ignores the renal protection and cardiovascular protection. So our approach should be beyond the glucose numbers we have to target. We have to focus on renal protection, and SGLT2 inhibitors and GLP-1 receptor agonists should be used as the first-line agents to control diabetes.
Chronic lymphocytic leukemia as the underlying cause for the paraneoplastic pemphigus.
And now, what if they develop DKD?
With extensive acanthosis nigricans of the neck, of the flexural area.
Can everybody mute the...
Veena madam, please mute your phone, madam.
That is hyperpigmentation with recursive
Veena madam.
arms, and she had underlying carcinoma stomach.
Okay, so now diabetes prevention, screening, early treatment with the renoprotective agents. What next? Annual screening for diabetic kidney disease. See, ADA recommends, KDIGO recommends, guidelines all recommends, but there is a huge gap between what is told in the guideline and what is practiced in the community. Many times this annual screening is often neglected. All diabetics should undergo regular annual screening with urine albumin creatinine ratio and blood creatinine at least once a year. So early diabetic kidney disease detection with regular screening and early and timely use of 4 pillars of diabetic kidney disease, the RAS blockers, SGLT2 inhibitors, GLP-1 receptor agonists, and Finrinol. This should be emphasized, and our general physicians, general practitioners, family physicians should be made aware of this strategy. Now, to conclude, the way forward is to empower the general practitioners, promote early screening of diabetes, use the HbA1c as a screening tool and as well as a monitoring tool routinely. Do not waste the golden period of diabetes. Adopt SGLT2 inhibitors and GLP-1 receptor agonists as the first-line agents in controlling diabetes, and also along with lifestyle and dietary changes, annual diabetic kidney disease screening, and early initiation of renoprotective therapy in diabetic nephropathy. Thus, beat diabetes early to prevent chronic kidney disease. Thank you.
Next, we will have Dr. Deepa KP for the next session. Dr. Deepa. Dr. Deepa.
Yes, madam. Am I audible, madam? Am I audible?
Yes, yes, you are audible.
Good afternoon, respected chairpersons, teachers, and my dear friends. I am Dr. Deepa KP, Assistant Professor in Nephrology, Assisia Medical College, Kollam. My topic today is Don't Let the Pressure Steal the Kidney. So my scheme of presentation will be Introduction to the BP categories, BP measurements, targets, and management of hypertension. Hypertension is a leading cause and complication of chronic kidney disease, prevailing in about 60 to 80% of patients with chronic kidney disease, rising to 90 to 95% in end-stage renal disease. So the cycle of damage between hypertension and CKD continues. These are the blood pressure categories suggested by American Heart Association, which where there is elevated blood pressure when there is 120 to 129, high blood pressure stage 1, 130 to 139 or 80 to 90 diastolic blood pressure. High BP stage 2 is 140 or higher and 90 or 90 or higher. So these are blood pressure categories mainly for studies conducted. If there is a chronic patient of a doctor and they see at least a 20 or 30 mercury increase of BP in the course of the disease, we have to take it as significant and not stick on to these BP categories. As Kaplan mentioned, the measurement of blood pressure is the clinical procedure of greatest importance that is performed in the sloppiest manner. So how to get it right? We have to avoid, the patient has to avoid smoking, caffeine, food or exercise 30 minutes before. That it should be done in a quiet room, comfortable temperature. The patient should rest for 3 to 5 minutes before the BP measurement. The patient should be comfortably sitting with back rest, legs on the ground, and the back should be straight, and the cuff should be of the correct size of length and breadth and in the heart level. So this is a comparison of blood pressure measurements, different types. First, the office blood pressure measurement, which is single or few readings can be taken using the standard automated or manual monitors. There is a risk of white coat hypertension. So out of office BP measurement, that is home-based blood pressure monitoring, where the patient measures blood pressure at home. And there are multiple readings over days and weeks, and this can identify mass hypertension. And the guidelines suggest that 2 morning or evening BP measurements first week of every month can help titrate antihypertensive medications and reduce BP. Coming to ambulatory blood pressure monitoring, it is the gold standard for diagnosis, where there is continuous 24-hour monitoring, readings taken every 15 to 30 minutes, and it calculates. This slide shows the comparison of different guidelines for BP in chronic kidney disease, where we can see KDIGO 2024 gives the target systolic blood pressure as less than 120 based on the SPRINT trial. Rest all the trials, which mainly consider cardiovascular outcome, they have a blood pressure target of less than 130/80. And this is because the more cardiovascular benefit comes in less than 130/80 compared to 140, and there is no difference between 120 and 130 in these studies for cardiovascular, but KDIGO 2024 suggests less than. So, according to KDIGO 2024, the target systolic blood pressure of less than 120 when tolerated using a standard office BP measurement is the target, and less intensive BP control should be taken in patients who are frail, who have a very limited life expectancy, who have symptomatic postural hypotension. These are the risk factors, which are personal, non-modifiable, and modifiable risk factors, which can be usually modified with lifestyle measures like weight management, healthy diet, sodium restriction, and regular exercise. Children with chronic kidney disease have to monitor at least with ABPM at least once a year, and every 3 to 6 months with standardized oscillatory office blood pressure. And now they have suggested a more strict control, with the target being 50th to 75th percentile of age, sex, and height. The slide shows the fundamental principle in combination therapy for hypertension, which includes the targeting different physiological mechanisms contributing to elevated blood pressure, which includes RAS, which is the most important mechanism, followed by sympathetic nervous system, sodium and volume controls, and arterial vasoconstriction. According to AHA and ASA journals published in late 2025 and early 2026, they have suggested starting a single pill control protocol where they start single pill control with 2 medications, half standard dose, followed by switching into 3 and then 4. Or there is an alternative approach where there can be monotherapy, one medication with initiating with half standard, followed by converting into full dose, then adding other medications. But they have not mentioned about patients or how to manage proteinuria, where we usually increase the RAS inhibitors to maximum standard dose and then add. This is comparing different blood pressure guidelines, and this slide just to show that RAS inhibitors are the first choice, especially with albuminuria, followed by CCBs or thiazide diuretics. These are the armamentarium that we have. RAS inhibitors are the major drugs, then followed by calcium channel blockers, thiazide, mineralocorticoid receptor antagonists, beta blockers. Diuretics, loop diuretics as well is there to control volume overload. Beta blockers, hydralazine, and centrally acting sympatholytics like clonidine and moxonidine. RAS inhibitors, for reducing the progression of chronic kidney disease, RAS inhibitors have been proved with renal trials, and just that there should be caution for use in elderly where they have higher atherosclerosis and they have who are prone to hypovolemia, where you should be careful in sick days. CCBs, we know nifedipine, which is a short acting. Now newer retard tablets and extended release tablets are available. They are safe in pregnancy. Reflex tachycardia is there. But cilnidipine, which is a hit in India, is a Japanese molecule, has reflex tachycardia, but it is less. And duration of action is just reaching 24 hours, so BD dose is preferred. Amlodipine is very stable, sustained, and powerful, and long has been used. It is highly lipophilic. The duration of action is 30 dosage is only required. Reflex tachycardia is less, and pediatric is there. Thiazide groups are usually preferred volume control or potassium management. Previously, it was considered the first line, then it faded because of compensatory RAS activation, hyponatremia, hypokalemia, and metabolic risk. It came back with CLICK trial, where it was proven to be useful for hypertension in advanced chronic kidney disease. Beta blockers, now usually the first line only in when you need a rate control. Carvedilol, bisoprolol, and metoprolol may be used. MRAs, aldosterone excess is common in resistant hypertension, as primary hyperaldosteronism is undiagnosed in most cases, and spironolactone blocks this final common pathway. And non-steroidal MRAs are, according to KDIGO 2024 CKD guidelines, there is a role of non-steroidal MRA in people with diabetes when along with RAS inhibitors. And in the same guideline, they have mentioned that initially we have to start with RAS inhibitors at the maximum tolerated dose, followed by dihydropyridines or thiazide diuretics. We have to individualize the treatment, and steroidal MRA may be added as a fourth drug for resistant hypertension if GFR is more than 45. In resistant hypertension, FDA has approved for renal denervation when multiple classes of oral drugs fail. Some of the novel medications with blood pressure effects that we should not forget is SGLT2 inhibitor in EMPA-REG BP trial. They have shown a 4 mercury decrease in BP, and GLP-1 receptor analogs have shown 8 in SURMOUNT trial, and sparsentan, dual endothelin angiotensin receptor inhibitor, especially used in IgA nephropathy, was shown to decrease BP by PROTECT trial. And we should not forget, when we prescribe many medications for blood pressure, when sick days come, you have to decrease temporarily these drugs so that the kidney can function. So the take-home messages are proper recording of blood pressure is crucial. Goal of blood pressure should be 120/80 when possible. ABPM is the gold standard for BP measurement. RAS inhibitor is the first-line antihypertensive, especially with albuminuria, with the caution of hyperkalemia and sick days. CCBs and thiazides may be used as second line according to the clinical scenario. MRAs may be used in resistant hypertension. Thank you.
Now, may I request the chairperson to give their comments?
Madam, Bimala Madam. Yes, I think Jyotipriya has very nicely highlighted the importance of controlling diabetes in the first few years. Because earlier we thought that when the diabetes is diagnosed, they go for diet, etc., and keep the blood sugar totally uncontrolled. And she has highlighted the importance of using targeted therapy. That is not only reducing the glucose numbers, but also using SGLT2 and dual GLP-1 agonist. The problem is the cost. You write simple drugs which are less expensive, they are likely to take it. But if you start writing very costly medications, my personal experience, they don't regularly follow the prescription and the default becomes very high. Anyway, Jyotipriya has very nicely highlighted the importance of controlling diabetes and getting CKD down. Dr. Deepa also in a very nice way put across the management of hypertension. Thank you, Deepa and Jyotipriya. Sajimi, you continue.
Dr. Deepa has one more presentation that is beyond the, she will present the next one also. Is there time? Okay.
Yeah, she can briefly cover the topic if she's already prepared.
Yeah, okay. Dr. Deepa, please unmute your. Okay.
Thank you, madam. I'll go to the next topic. Beyond the biggies, the overlooked strategies in CKD prevention. The theme of presentation will be introduction, application factors, tobacco prevention, managing the internal milieu, and take-home message. Chronic kidney disease is a growing health problem with the prevailing in about 1 in 10 survivors, usually on glycemic control and blood control. But still we see that patients progress to even after controlling these factors. So we have to look beyond the obvious. So we'll be mainly dealing on the lifestyle modifications, including healthy diet, physical activities, stopping the use of tobacco products, and weight management. So what is a healthy diet for chronic kidney disease? Plant-based diet is better than animal-based diets in chronic kidney disease, as plant-based diets have low food and uremic toxins are lesser. So eventually they cause a lesser hyperfiltration and they are good for gut. So, but on the contrary, animal-based diet have increased acid load, phosphate, uremic toxins, eventually having a higher hyperfiltration, and they have a gut dysbiosis, which causes faster CKD progression. So plant-based diet have reduced inflammation, which translates into decreased cardiometabolic risk, hypertension, better control of diabetes, and obesity, shown by slower EGFR decline, reduced proteinuria, lower risk of kidney failure and mortality, and improved quality of life. Comparing the different diets, dietary approach to stop hypertension diet, which was mainly studied for lowering the blood pressure, which included a protein intake of 0.8 to 1 gram per kilogram per day, and more of fruits and whole grains were used. In Mediterranean diet, it was mainly for heart health and longevity. It included 0.8 to 1.2 gram per kilogram per day and includes fruits and vegetables, and proteins were mainly fish and seafood. In Plado diet, which is plant-dominant low protein diet, which was mainly for chronic kidney disease, and it included plant proteins, plant-based proteins like tofu, tempeh, seitan were used, and it had only 0.6 to 0.8 gram per kilogram per day. That was mainly studied for chronic kidney disease. Protein, as we mentioned earlier, there should be a moderate restriction of protein intake of 0.6 to 0.8 gram per kilogram per day, which should be usually more of a plant-based protein, and we can choose lean meats. Consultation with a registered dietitian may be required, and in children especially, we have to see that there can be a risk of growth impairment when we restrict protein. In geriatrics also, 1 to 1.5 gram per kilogram is advised to prevent age-related sarcopenia. And the keto analogs mainly advised only if there is very low protein diet intake of less than 0.3 gram per kilogram when to avoid protein energy malnutrition. Sodium intake is, by guidelines, they suggest less than 5 gram per day, and sodium of less than 2 gram or 90 millimoles. We should avoid processed food, and it can be made more tastier with flavors and herbs. And these sodium restriction can cause decreased BP and decreased levels of albuminuria, with a caution in patients with salt wasting kidney disease, malnutrition, and who live in extremely hot climatic conditions. Coming to physical activity and optimal weight management, guidelines say at least 150 minutes per week of exercise is required, with 2 sessions of resistant exercise may be considered. Walking, cycling, strengthening training, and yoga may be considered. This is good for heart health. It lowers blood pressure, weight management, and slows CKD progression. In children, CKD WHO advised 60 minutes of daily exercise. And this should be only when it is compatible with their cardiovascular and physical tolerance. BMI around 25 should be maintained, and the new drug GLP-1 log is showing great results. Now, avoiding use of tobacco products decreases risk of associated premature mortality by improving the vascular health. Lung cancers, cardiovascular disease, all can affect kidney disease progression. Intensive nurse-led programs with smoking abstinence and pharmacological intervention is very useful. Now, managing the internal environment, metabolic acidosis. We have to prevent serum bicarbonate going below 18 millimoles per liter. It decreases chronic kidney disease progression and it causes bone and it affects bone and muscle health. Bicarbonate should not exceed the upper limit of normal, as it has deleterious effects on BP control, phosphate levels, and fluid status. Optimum bicarbonate levels are necessary. Hyperkalemia mainly is to be done, management is mainly to be done to restrict, because hyperkalemia restricts the use of other CKD preventive therapies, and we should tell them to avoid local fruits, especially the mango, jackfruits, banana, tender coconut water should be avoided. And hyperkalemia drugs with chronic kidney disease preventing drugs like finerenone or RAS inhibitors have been advised. The new guidelines have suggested not to stop RAS inhibitors or MRAs. If hyperkalemia is there, we can use anti-hyperkalemic measures along with them. Coming to plant-based foods, there also plant-based foods are more advantageous than animal-based foods, because the potassium from the plant-based food absorption rate is less, 50 to 60%. Hyperuricemia and gout management. Uric acid lowering therapy to patients with CKD and symptomatic hyperuricemia should be treated. Consider after first gout episode, if CKD is stage G3 to G5, serum uric acid is more than 9, there is a history of urolithiasis, and there is no avoidable precipitants. We can manage it with low-dose colchicine, glucocorticoids, and intra-articular steroids. We should avoid NSAIDs in treatment of gout, and mainly we should focus on non-pharmacological prevention of alcohol, red meats, and high fructose corn syrup. And we should especially take care that uric acid lowering therapy is not required for asymptomatic hyperuricemia. CKD MBD management has to be considered properly for lowering the phosphate by low phosphorus diet and phosphate binders, treatment approaches of vitamin D therapy and calcium mimetics when required. We should not forget to treat anemia properly and coronary artery disease. Timely management of coronary artery disease is important. Low-dose aspirin should be given to prevent recurrent ischemic attacks, and treatment of systolic and diastolic dysfunction of heart is to be done properly. Cardiac interventions should be done at proper time if necessary. In chronic kidney disease, there is high levels of triglycerides and LDL. So CKD patients who are aged more than 50 need to be with lipid abnormality should be treated with statins with or without ezetimibe. And with age between 18 to 49, if we have to check for the risk factors, if any one of these is present, like coronary artery disease, diabetes, prior ischemic stroke, or 10-year MI risk of more than 10%, statin therapy should be started. PCSK9 inhibitors if indicated. And briefly, we should avoid NSAIDs and indigenous medications. Sleep hygiene and screening for OSA is vital. Heat safety and hydration, especially those working under the sun for prolonged duration and taking high fructose syrup for hydration, they should be careful. And vaccination, not only hepatitis B, pneumococcal influenza vaccines are very crucial. We have to avoid infections, especially leptospirosis, scrub typhus. All can cause a worsening of the kidney function during the infection, and each AKI will is a step towards CKD, end-stage renal disease. There should be regular monitoring of BP and albuminuria in patients, in especially children with recurrent UTI who had renal scarring, history of posterior urethral valve or vesicourethral reflux. Patients with history of gestational hypertension and GDM should be monitored regularly. And lastly, in glomerular diseases, especially IgA nephropathy and complement-mediated diseases, there have been newer drugs which decrease proteinuria and which also help in preventing the CKD progression. The take-home message will be glycemic control and BP management are vital. Dietary modifications, especially moderate protein and predominantly plant-based diet is ideal. Avoid tobacco products. Aim adequately for physical activity and weight reduction. Maintain the internal milieu with focus on bicarbonate, potassium, uric acid, calcium, phosphorus. Management of lipids, anemia, and coronary artery disease go hand in hand.
Next, we have our World Kidney Day celebrations activities by our Kerala chapter. It will be done by Dr. Ambili.
Audible? Am I audible?
Yes.
Ambili, is the screen visible now?
No.
No, not yet.
Brand ID under the same name. The Cellphos HTK Plus comes with its
No, in fact, Saivani's screen is visible.
Yeah, madam. She asked me to show the screen.
Oh, right.
And Ambili, please finish off early.
Yeah, I'm delighted to share the glimpses from across Kerala on how women in nephrology observe the World Kidney Day to promote kidney health in our communities. So I think we can have the video on.
for intelligent retrieval transmission, which is based on the CBT. What does it have? It's a chain system, while the CBT has a push button system. Other than that, there's no difference. The Korean brand IDT sells it under the same name.
You have to put on the video, Saivani.
Madam.
You have to put on the video.
Video is not visible.
Are the
Yeah.
images?
Okay.
Yeah, you have to play there.
It's not playing, madam. Otherwise I will scroll the thing.
All right.
Can you tell Ambili?
Yeah. Okay, so this was actually a short movie presentation which was highlighting the activities led by a dedicated women nephrologist and healthcare team across the state in spreading awareness and screening patients and advocating good practices of kidney health. Different activities included community outreach health camps, screening in communities, and interactive health talks on TV channels, and planting trees near dialysis centers to promote the health of our Mother Earth, and various competitions for undergraduates and postgraduates like poster making and quiz competitions and street plays, flash mobs, and entertainment, including a dance by a young kidney transplant recipient.
The Korean brand ID sells it under the same name. The Cellphos HTK Plus comes with its IVT, which stands for
Also, the Health Department of Kerala launched an initiative for the early detection and comprehensive management of renal disease among children and it has been named Pratiksha. And special mention about Dr. Susan Udup, the pediatric nephrologist who played a vital role in initiating this, and it was a dream come true for her.
Variable transmission, which is based on the CBT. What does it have? It's a chain system, while the CBT has a push button system. Other than that, there's no difference.
This was a health camp organized by Dr. Smita and team.
The same name. The CellTOS HTK Plus comes with its IVT, which stands for Intelligent Variable Transmission, which is based on the CBT. What does it have? It's a chain system, while the CBT has a push button system. Other than that, there's no difference. The Korean brand IVT sells it under the same name. The CellTOS HTK Plus comes with its IVT, which stands for Intelligent Variable Transmission, which is based on the CBT. What does it have? It's a chain system, while the CBT has a push button system. Other than that, there's no difference. The Korean brand IVT sells it under the same name. The CellTOS HTK Plus comes with its IVT, which stands for Intelligent Variable Transmission, which is based on the CBT. What does it have? It's a chain system, while the CBT has a push button system. Other than that, there's no difference. The Korean brand IVT sells it under the same name. The CellTOS HTK Plus comes with its IVT.
Each image reflects the commitment of our nephrology team across Kerala to bring kidney health awareness closer to people.
Korean brand ID sells it under the same name. The CellTOS HTK Plus comes with its IVT, which stands for Intelligent Variable Transmission, which is based on the CBT. What does it have? It's a chain system, while the CBT has a push button system. Other than that, there's no difference. The Korean brand IVT sells it under the same name. The CellTOS HTK
There's a blood donation camp. GGO Hospital also had a street play and an interactive session. This was an article in one of the newspapers.
Now I request our chairperson to give their conclusion message.
Yeah, from the state of Kerala, we have focused more on diabetes, hypertension, and various risk factors for chronic kidney disease, and how we can prevent the epidemic of CKD in the future. We ourselves, our colleague physicians, and the general public should be aware of the importance of control of diabetes and hypertension from the day one of their diagnosis. This is very important. Otherwise, it is not easy to block the epidemic of CKD. And the World Kidney Day in the state of Kerala, almost all hospitals have taken up the World Kidney Day with very good spirit, and all of them are doing something or other in order to spread the message of importance of kidney disease. Dr. Gaumati?
So what I would suggest is we have to concentrate more upon the obesity as well. Obesity is a growing epidemic, and that is responsible for diabetes and kidney disease. And moreover, obesity without diabetes and kidney hypertension, it can lead on to kidney disease directly. So it is becoming an epidemic even in childhood. So we have to catch them young. That is very important.
That comes to the
It's a
Yeah,
very
thank
nice
you.
presentation from Kerala chapter on prevention, diabetes, hypertension, and obesity management, and all the activities done very wonderfully done and very wonderfully shown also. And we'll move on to Maharashtra chapter. Thank you, everyone.
Thank you, Dr. Saivani. It was very heartening to see how all state chapters have come together today, and we are showing the solidarity of the whole country in what all activities we are doing, and we are all united for the cause of World Kidney Day. It has been a very wonderful experience witnessing this since morning. To tell us about the Maharashtra activities, I would like to invite our chairpersons. It gives me immense pleasure to invite Dr. Kalpana Mehta, Madam, who's now a consultant nephrologist and transplant physician at the Breach Candy Hospital, Mumbai. And she was the professor and head of the Department of Nephrology at the TN Medical College and BYL Nair Charitable Hospital, Mumbai. Madam has actually built the Department of Nephrology from scratch in Nair Hospital. She is a teacher par excellence, and we are very, very happy to have you, Madam. And she's joined in the chair by Dr. Rasika Shirsat, Madam, who is a very senior consultant nephrologist from the city of Mumbai. She's heads the unit in the PD Hinduja Hospital, Mahim and Khar Hospital, Mumbai. She is also a great mentor to all young nephrologists in the city of Mumbai and in Maharashtra. Over to you, chairpersons.
Dr. Rasika, please go ahead.
Yeah, good afternoon, everyone. It was a pleasure.
Hello.
And the theme being environmental, I think we should also focus a little bit on CKDU, which we are seeing in Maharashtra, especially in the Vidarbha and Nagpur district. So I think that is a very important point as well. And we celebrated the World Kidney Day by doing 2 programs, which Dr. Geeta and Dr. Sayali will tell us about what all we did in that. So I will not dwell on that. And also, I would like to say that we got the information very late for this program. So we have not made any talks. We will just show you what we have done on the 2 days that we had the program. And I request Kalpana to give her views now. Kalpana?
Yeah, actually, Dr. Geeta, I think we'll say Geeta, who is a professor and head at JJ Hospital, and she's also secretary of in Maharashtra along with Dr. Divya. We'll just narrate what exactly did it on the World Kidney Day. And I'll just comment it here. One thing is that, as some earlier speaker had said, that we focus basically on the general physicians because they are the primary care physician where all our patients usually go. So we had this awareness program and teaching program for this, where we had 174 registrations. So over to you, Dr. Geeta. Just narrate what we exactly did on that day, on 11th March. Dr. Geeta?
Dr. Geeta, madam, we can't hear you. If you can just mute and unmute again. You are unmuted, just mute and unmute. Still can't hear you.
Yeah, we can see you.
Can't hear you still. If you can just check your microphone in audio settings, if you can just click on the small tiny arrow which is besides the microphone icon.
Am I audible? Am I
Yes,
audible?
yes, yes,
Now,
yes.
yes, now, yes.
Now you're audible.
Thank you, ma'am. Good afternoon, everyone. I would like to share the events which we did in as a team in Win Maharashtra. So, happy World Kidney Day. We on 14th March we conducted an online CME, and this CME was basically for patient education and to solve patients' queries. And this we actually reached out to people, the nephrologists across Maharashtra for this program and patients across Maharashtra for this program. We had panelists, Dr. Zope ma'am, Shirshat ma'am, Monali Sahu, who was from Nagpur, and we also
Ma'am,
had.
you have slides. You have slides, right? If you can share them. It's not shared, madam.
The slides are not seen?
No, madam.
No.
You need to share the slides.
Are my slides seen?
No.
No, madam. I'll.
Okay, now can you see it?
No. No, no, no.
Madam, I have your PPT. I can share it from my end.
They are seen now.
Yes. If you can do in PPT mode. Yes, perfect, madam. Madam, unmute.
I think it's okay. I mean, she can present like that only. It's not a problem. Divya?
Geeta, madam, please unmute yourself. Yes, madam. Now you, ma'am, you,
Now,
ma'am, you can need to share your slide again.
Are the slides visible?
No.
Anyway, otherwise just start speaking, Geeta. Otherwise we are behind the time.
I will share slides, madam, from my
Divya,
end.
please share. Please share.
Yes, madam.
So on 15th March, we had an on the 14th March we had an online patient advocacy program, and we reached out to female nephrologists across Maharashtra, and patients were also included from across Maharashtra. This was a 2-hour program, and uh, we had a discussion on hypertension and diabetes, then on dialysis and transplant. And later on, we had 2 patients actually who discussed their journey through kidney disease, undergoing dialysis and then undergoing renal transplant. So one of them was from Kerala, Nisri, and the other patient was from Nagpur. And they actually shared a lot of positive vibes for all the patients who had joined online. And then after that, we had a question and answer session where the patients asked us questions in local language and regional language, and we answered those questions. And this was a great program. This lasted for around 2 hours. Divya, change, yeah. So, and the second program, this was a hybrid program, and this was conducted in KM Hospital. And because of the theme of the World Kidney Day, we actually restricted to talking about the lifestyle diseases in the CME. This was collaborated with the Indian Medical Association to create awareness and educate the general practitioners. And we had around 174 registrations in all. And our target audience at that time, this time, was general practitioners. So the program actually started with inauguration. Our chief guest for this program was the Dean of KM Hospital, Dr. Sangeeta Raut, and past state IMA President, Dr. Santosh Kadam. We had two eminent speakers in this program who were also the IMA office bearers. Dr. Girish Rajadyaksha, who spoke on how I will treat hypertension in 2026, and Dr. Mangesh Tivaskar, who spoke on how I treat diabetes in 2026. These lectures were then followed by panel discussions. There were 4 panel discussions in all, and each was moderated. The first one was moderated by Dr. Divya Vajpayee, and the topic was obesity. The second panel discussion was moderated by Dr. Saili, which was on diabetes. The third was moderated by myself. It was on hypertension. And the fourth panel, we kept the pediatric nephrologist in this panel, and we focused on lifestyle diseases in children. And we had around 36 female nephrologists all across Mumbai who participated in this panel discussion. And we had around 120 participants online plus the physical presence for the CME. So this CME also was a big success. And also in the future, we are looking forward to the other WIN activities, and we'll continue to connect with all the female nephros all across Maharashtra and keep doing awareness programs. Thank you, ma'am.
Just wanted to mention that we are missing Shruti Tapiawala madam here. She could not join because of some family emergency. Over to chairpersons for their comments and closing remarks.
Yeah, I mean, from my side, I would say, of course, the messages have been given by earlier speakers about our usual protocol for prevention. But I just came across a recent article in Kidney International Reports, where they say that triple therapy, which we are commonly using, should start as early as A2. And these patients don't come to us at that time. They are usually with general practitioner. So that was how we should really attack and increase our community programs so that the general practitioners refer patients to us earlier with all these 4 important parts: diabetes, hypertension, obesity, and of course the main group which was taken into our discussion, that is children. So this should be focused. That's what I would say.
Yeah, I concur with Kalpana. And also, I think in the pediatric session, we had a discussion about mother's nutrition and the effect of that on the fetus and the growth thereafter and the risk of metabolic syndrome in those children. So that is also a very important point because these children tend to develop obesity, blood pressure, diabetes later on in life. So I think that point is also was well taken, and it was discussed extensively in the panel discussion. So I don't think I have anything else to say. Thank you.
Okay, thank you, chairpersons. Over to Dr. Saivani for the next chapter.
So that's a wonderful gesture from WIN Maharashtra, and nice webinars on important topics and pertinent topics covering the pediatrics also, because now pediatric CKD is going and rampant, especially in our Andhra Pradesh also impaired kidney function is very high. And so nice message from Maharashtra. And now we move on to North. Medhavi, are you available? And Medhavi will moderate the session from North.
So, hello. Good afternoon, everyone. So today, as we come together to celebrate World Kidney Day, it gives me immense pleasure to see the remarkable enthusiasm and dedication shown across North Zone, whose work has been truly inspiring. Although Dr. Urmila ma'am couldn't join us today due to her busy schedule, we are grateful for her constant encouragement and blessings as we begin this session. It is now my privilege to invite our chief guest, Dr. Swaranjit Kaur ma'am, to deliver the welcome address. She is a highly experienced patient-focused nephrologist with over 12 years of clinical experience, currently practicing in Bhatinda at Pregna Hospital. Over to you, ma'am.
Thank you, Dr. Medhavi. A very good evening and warm welcome to all the participants of this web seminar. And thank you, Dr. Medhavi, for coordinating with me and giving me an opportunity to interact with you all. And for those who are not familiar with me, let me just give a brief introduction to myself. I am practicing in Bathinda, Punjab, and I did my training from PGI Chandigarh in the year 2007. In those times, there were very, very few female nephrologists in India, and in North, we were only two female nephrologists, myself and Dr. Raka. And when I entered PGI, I was told that PGI is very unwelcoming to the female residents, and a female is entering the department after a gap of 20 years. And to add to my challenge, I was expecting I was in the middle trimester of my pregnancy when I cleared the entrance examination. And my looks were quite deceptive, so nobody could judge me. And luckily, I secured a seat in the middle of my pregnancy. And there was no provision of maternity leave. Asking for maternity leave was kind of a professional taboo. But thanks to my mentor, my teacher, Professor Sakuja, he accommodated me and he granted me a leave of 3 months, that a resident was entitled to a 30 days of leave in a year. So I availed all 93 years leave in the first 6 months. And the price later on I paid was I was not given a single leave for the next 2.5 years. I could not visit my daughter. I could not visit my hometown. So in those times, getting a training in nephrology was a huge challenge. So today, as I see, the woman power in nephrology has increased. So many women nephrologists across the India and all over the globe. So as a woman power, we are positively impacting the healthcare with our unique perspectives. And Win India has grown into a very powerful organization, and it is addressing the challenges which are being faced by the females, providing support, and we have built a very strong female community of nephrologists. So from the group, I can see that our North Zone has very actively and very enthusiastically organized various activities to celebrate and mark the World Kidney Day. And today, in our meeting, we have basically two agendas. We are going to display the what kind of activities at various centers of North Zone that has been organized. And second is we are going to have a small panel discussion on the kind of challenges a female patients feel while having access to the healthcare. So over to you, Dr. Madhvi, and thank you for having me here.
Thank you so much, ma'am. Thank you. I will now take the privilege to share WKD activities across different centers of North Zone. So I'm sharing my screen. I hope my screen is visible to everyone.
Yes, it's visible.
Thank you. Thank you so much. So I will start with Dr. Urmila Anand ma'am. She needs no introduction, and she has always been a forefront of the community outreach activities. As a part of WKD activities, she had a special focus on early detection of kidney disease using point of care serum creatinine and USCR testing, especially among advocates in rural Haryana. And her activities were also recognized and appreciated in the newspapers, highlighting the importance of such activities. So Thank you so much, ma'am. Here is ma'am herself counseling the patients, and very beautifully, very enthusiastically. She is Dr. Anupama Kaul, ma'am, professor in the Department of Nephrology at SGPGI. And on the occasion of World Kidney Day, she organized a very meaningful and felicitation program for the family members of the cadaveric donors. We hope that such initiatives will certainly help in giving greater momentum to cadaveric transplant programs in India. Also, a walkathon was organized by her department, emphasizing the importance of early detection and prevention while spreading the message of World Kidney Day. So WIN is about inclusivity, and we can see lots of men participating in walkathon, although ma'am is not visible here. Next is Savanjit Kaur, ma'am. So ma'am was very enthusiastically and beautifully, she has reflected her commitment to spreading awareness about kidney health. These are some of the photographs which ma'am has shared from her hospital, and thank you so much, ma'am. Next, we have Dr. Namrata Rao, additional professor at RML Institute of Medical Sciences, Gomti Nagar, Lucknow. She conducted an outreach activity screening people at RHTC Jugar. 90 patients were screened for blood pressures, random blood sugar, serum creatinine, and spot urinary PCR. Thank you, ma'am. We have Dr. Harmeet Riyat from Jalandhar, and she organized poster competitions to encourage awareness and engagement. And she also facilitated patients who have been managing their illness with great determination. These are some of the posters from her department. Conducted activities about awareness about kidney health. She's Dr. Navjot Kaur, and the team marked the occasion with a cake cutting ceremony in the dialysis unit, and also delivered educational lectures. Dr. Suman Sethi is from Ludhiana, and she organized a special program titled Dil Se Fighter, a gathering of strength and support, spread awareness about kidney health, treatment options, and life after transplant. The sessions were interactive, wide media coverage was there, and also the patients were engaged with a cultural activity. So, thank you, ma'am. Lots of activities and felicitation was organized by her department. She is Dr. Pallavi Prasad from Safdarjung Hospital, New Delhi. She distributed water bottles and high protein diet to the patients. Also, an awareness program was conducted at her center. Dr. Sakshi Jain from Lucknow. Very beautiful program. And she also presented bravery certificate to patients, kidney donors, and their family members. Dr. Chandni Bhagat from ILBS New Delhi. He is Dr. S.K. Sareen from Director ILBS and addressing people. So he is a transplant patient, and we'll also have a performance from his side. So she also invited celebrities across. He's Dr. Ashok Chakradhar, who is a great poet and a very well recognized name. And she used the enthusiasm and the dynamic nature of the celebrities to spread awareness about kidney health. We have Kajri Giri from Belmed Tri-City Hospital, Punjab. She organized a medical camp on 11th March, and also her activities included poster making competitions, quiz, health talk on green dialysis on 12th March. And these initiatives beautifully combined with awareness, learning, and community participation highlights the spirit of celebrating World Kidney Day from her side. She is Dr. Nivedita from Apex Hospital, Varanasi. She organized a student awareness program at Apex Paramedical Nursing and Physiotherapy College, Varanasi. The program saw active participation from nursing faculty and clinical dietitians. And an inter-college painting competition was also conducted on the theme Healthy Kidneys and Healthy Planet, encouraging students to creatively spread awareness about kidney health. Thank you, Nivedita. These are glimpses of the poster competitions and the drawing competitions also. Beautiful drawings from students all across. Dr. Soumya Gupta, assistant professor in Prayagraj. And on this occasion, she had a special focus on dietary counseling for CKD patients and also those on dialysis. 80 individuals were screened using urine routine test and kidney function test to help identify patients at an early stage. So it is a huge number. She is Sana. She has shared her video. We'll play that. Sana is from Varanasi. This video is self-explanatory. Shows her dedication and awareness. So we from KGMU, Lucknow, conducted a 2-day program on WKD. So day 1 started with a Nukkad Natak or street play organized by the dialysis diploma technicians. Also the patients were felicitated for their determinations. They are fighting this chronic illness. A poster competition was also organized. On day 2, we had a quiz competition for MD postgraduate students and winners were felicitated. Also, we had invited alumni consultant who completed their MD from KGMU and now practicing in the city. So meeting them and interacting with them, also the MD students, was a very nice experience. She is Dr. Mansi Singh from Regency Hospital, Kanpur. She has only shared her flyer because her department is organizing the activity on 29th of March. So thank you so much, everyone. I'm very grateful to everyone for sharing their work with us. Thank you so much. Now we move on to the panel discussion. Our young and enthusiastic team from different parts of the North Zone is all set to share their views and experience. For this session, I would like to hand over to Dr. Jasmine, additional professor in the Department of Nephrology at PGIMR Chandigarh, who will introduce the chairperson and the panelists and moderate the discussion. Over to you, Dr. Jasmine.
Thank you, Dr. Medhavi. I am still an associate professor, recently promoted, not additional. So moving ahead, we'll now go on to the panel discussion, women with kidney disease and the North Indian perspective. To introduce this session, I will like to invite Dr. Namrata ma'am, who is an additional professor in RML Lucknow. Ma'am will introduce the topic and then we'll move on to our panelists to give their views and insights on it. Dr. Namrata ma'am, to please introduce the topic.
Hi, Medhavi. Hi, Jasmine. And very good afternoon to all the seniors who are in the session late this afternoon. The topic on which I think the North Indian perspective is important and possibly often overlooked, even in the setting of whether it is ISN or WIN, is that how is kidney disease in women in this region of India? We are possibly some of the most populous states across this region, and pregnancies and pregnancy complications still constitute a huge burden here, and maternal mortality rates are much higher in this region of India than elsewhere. So the perspective of women nephrologists, who first being women and then being nephrologists, are all, I mean, obviously looking at things in a much more lucid fashion, is something that I would also be looking forward to discussing this aspect with many young nephrologists from this region. So it's my privilege and honor that I've been asked to chair this session. We have a number of speakers here. Maybe Jasmine, you could go about with the question and then introduce each speaker as you go.
Yes, thank you, Dr. Namrata. So, Dr. Chandni, we would like to know why women with kidney disease often seek medical advice very late in their course of disease. So, in your experience, what are the barriers that prevent women from seeking medical advice? And they often come to our attention very late. So, what are the barriers that are present here in this region?
So, good afternoon, everybody. Thank you, Jasmine, for introducing me, and Dr. Namrata Medhavi. I think in a country like India, particularly in large North Indian cities like Delhi, the barriers for women seeking timely kidney health care are usually social and structural rather than purely medical. So there are certain recurring themes which I would like to focus here. One is like financial dependency and prioritization of male health. So, this translates into women presenting late to us. Second is low awareness of kidney disease and its silent progression. The problem further gets amplified because routine screening of diabetes, hypertension, proteinuria, less frequently done.
and some redefined
Then
scale
there is a
areas
third point which I
Dr.
would like
Bina,
to
can you please mute yourself? Dr. Bina Krishnan.
Veena, madam, please mute yourself, madam.
Hello.
Arifa, you can mute
Yeah, I'm
from your
here.
side.
Can you see me? Hello.
Madam, please mute yourself, madam.
Yes. Hello. Can you introduce the speaker? I will conclude. I'll talk
No,
at the
no.
end of the
You can
conclusion.
mute yourself now. When your turn
Yeah,
comes,
I will
I
do.
will ask you. Yeah.
So basically, we discussed 2 points. That the first one was financial dependency and prioritization of male health. This translates into women presenting late. Second is low awareness of kidney disease and its silent progression. Then the problems get further amplified because routine screening of diabetes, proteinuria, and hypertension is less frequently done. Third is gender norms and lack of decision-making autonomy. So basically, that leads to missed follow-ups and delayed nephrology referral. My fourth point is basically the caregiver burden and neglect of personal health. So usually, the females are like symptoms like fatigue or edema or anemia. They're actually dismissed as weakness or workload. Then there is health system barriers. That is shortage of nephrologists and specialized persons due to the patient load and also long waiting times. Sixth is gender disparity in advanced therapies. We have already seen that women are mostly donors, organ donors, rather than lesser recipients. So here I would like to mention that, mainly early symptoms are ignored, limited screening for CKD risk factors, financial and family approval delay, and presentation when already the disease has already progressed. So I would like to suggest certain practical strategies to overcome these barriers, like opportunistic proteinuria and blood pressure screening in women attending clinics for any reason. Secondly, community awareness programs and diabetes, hypertension, kidney health clinics, counseling families that early CKD treatment is actually cheaper than dialysis, and integrating kidney screening into women's other health camps. Thank you.
Thank you, Dr. Chandni. That was very informative. Now we move on to Dr. Sana, who is working as assistant professor in Banaras Hindu University. So, Dr. Dr. Sana, we would like to know your views that what challenges do women what challenges do women face in assessing dialysis or specialist kidney care in especially rural areas? So, Dr. Sana.
Good afternoon, everyone. The most important challenges which our patient faces first is the geographical isolation. Those patients who come from rural areas, most of them, they don't know how to drive. They don't have a driving license. They cannot afford for a private vehicle. So they depend on their family members to transport them from their home to the dialysis centers. And these dialysis centers, some of them, they even come from 100 kilometers far away. So this is the biggest issue which they face. And most of the time we tell them like you have to do a dialysis for twice a week or thrice a week, they often miss the dialysis sessions. And even some patients, so they deny, they cannot come far from their home and get the dialysis done. Second is, as Dr. Chani has already discussed, that financial dependence, which is the most important factor when we come to talk about dialysis. These most of the women, they are homemakers and they don't have any personal income. So when it comes to dialysis, when it comes to bearing the cost of dialysis, they are not prioritized as compared to the males in their families who are considered as the breadwinners. And thirdly, and most important is the the third is the most important is the traditional role as a gender role. They are considered secondary to the male members of their family and they are not every time prioritized. Fourthly, lack of trained staff and at the PHCs or the health centers which take care of them, lack of delay in referral, seeking the super specialist care to these patients. And above all, the most important challenge in these patients which we face, we often see the patients who come from the rural areas, they are illiterate, they are financially dependent, and they lack the decision-making power for themselves only. And when they don't even take their decisions on their own, their family members are also not prioritizing their health and it subsequently delays their overall health and delay in dialysis and the referral to the specialist clinic. Thank you.
Thank you, Dr.
In fact, I have just, I mean, what Sana was saying, I would agree with that. Recently, we were doing a rural, we have been doing a study, a community prevalence study in a rural area. Many a time, women say that they have to seek permission from their husbands for blood sampling. So it's very absurd as to how any kind of care has to be sourced through the men of the family to be able to, receive or even seek any kind of care. So it's quite true. That's possibly a very big barrier. Another barrier, as Chandni was saying, regarding, one thing that was just observing, urine test which shows you some blood or some protein could just be from the vaginal tract. And people are likely to attribute it to Krana. So, it's somewhat a gender barrier for that as well.
As both Dr. Chandni and Dr. Sana have mentioned that main barrier for women accessing healthcare is their financial dependency and their dependency on a male caregiver to take all the decisions. To take this forward and also to elaborate the role of illiteracy in accessing these healthcare facilities, we would now like to invite Dr. Sakshi for her comments. Dr. Sakshi is working as a senior nephrologist in Charak Hospital, Lucknow. So, Dr. Sakshi, please.
Good evening, everyone. Thank you, Win North, for the opportunity. I think for the topic, it's a tough topic, and already it has been discussed by other two discussants that the financial dependency is a huge barrier, especially for the females in India, and often women themselves prioritize their family needs over their own health, delaying diagnosis and the treatment. Sometimes when these symptoms of weakness and lethargy and pedal edema, when the symptoms appear, they themselves ignore saying that they are under stress. Even when we see the patients who are coming, the ESRD patients, when they come to our OPD, if we take for an example, they come with their husbands and we ask them why the husband is not being a donor for the kidney. So sometimes female themselves say, even if the husband is ready to give, though very lethargically they say yes to donate their kidney to their wives, but when they even agree, the wives diligently says that we will die rather than taking our kidney from our husbands, or this can't happen that we can take our kidneys from our husband. Even if we counsel them, if your husband would have suffered from ESRD, then you would be giving your kidney to him. So they are readily agreeing that we would be giving our kidney, giving our kidney. But when it's come to the part of taking the kidney from the male members of the family, they themselves are very reluctant. I think the main factor which prevent them from the thinking process or the thought process is the education. The lack of education is the main thing which prevent them from anything, from doing anything or taking any decision for themselves also. They think that even if they spend a penny or some amount of money or time, or any of the health resources are being spent on them, they are made felt like the family is doing something very means they are doing some favor on the female, or the female is draining the family budget or the money. So I think this financial dependency and the lack of decision making, and both these things come from the lack of education of the female members of the family. I think this is the main shift of the power dynamics towards the male member, and which prioritize male family member health or or their financial stability over female presence only, thus affecting the treatment outcomes in our women patients.
Thank you, Dr. Sakshi. We agree to all your comments. Moving ahead to now Praki-related illnesses. So pregnancy-related AKI contributes a major chunk of women kidney diseases. So many of times we see that obstetricians do not refer the patients timely to nephrologist, and they only refer once they become CKD, end-stage kidney disease. So to discuss this lack of coordination between nephrologists and obstetricians, we would now invite Dr. Karavi, who is working as a associate professor in Sarojini Hospital, Agra, to shed some views on this point.
Hello, good afternoon, everyone. So, if I talk about pregnancy-related acute kidney injuries, one of the most dreaded complication on the part of the obstetrician. So, if we talk about AKI cases in general, PRACI constitutes around 1 to 2% of all cases of AKI being reported. And if we talk about women in general, so PRACI constitutes around 20 to 30% of cases of AKI in them. So, that is quite a number, a significant proportion of disease burden in women. If we talk about mortality rate, it is quite high in cases of PRACI. It is ranging from 25 to 35%, and especially in North India, there have been reported studies where they claim that the mortality is more than 30%. So, because of the nature of the disease, the high mortality risk, obstetricians quite fear this complication. So, in our region where I practice, I have noticed that obstetricians are quite prompt in sending referrals. In our medical college, within hours of a fall of urine output, say if a patient doesn't get urine in 2 hours or 4 hours, they are the first people to notice and send us a referral. From the nephrology part, also, such cases are being immediately responded to, and most of such cases are transferred to the nephrology unit as fast as possible because usually they require dialysis in next 24 hours. However, if the cases we talk about outside the city, the patients coming from periphery who are being delivered outside in small villages, they come late to us. They sometimes present from day 3 to day 5 of the onset of AKI. These are the ones which are more complicated with a higher mortality ratio. They require ICU care, many times ventilatory and inotropic support. So these patients who are coming late to us are the more complicated ones. But as the time is increasing, now we have around 12 to 13 nephrologists in Agra itself. So to find a nephrologist here in city itself is now becoming more easier, and referral system is getting better coordinated. And I think the response rate from the part of the nephrologist is also improving day by day.
Thank you, Dr. Karavi. To go ahead further on this line only, so what improvements we can suggest to improve this coordination and improve maternal outcomes in cases of pregnancy-related AKI? We would have the comments of Dr. Mansi, who is working as consultant nephrologist in Regency Hospital, Kanpur. So, Dr. Mansi, for her comments.
So, a very good evening to all present. Thank you for giving me this opportunity. So, as ma'am has rightly said that it's basically an early referral and quick response to such cases, which actually win the battle, save lives. But mostly, what we find is sometimes the outcome of Praki is so poor that the patient are often dialysis dependent for the rest of their lives. So, I think a step before this is antenatal counseling itself. So antenatal counseling is sometimes very important because when we see a patient in her third trimester or postpartum phase, we cannot even find a single report of urine routine microscopy or KFT with that patient. So I think a system should be built upon so that the gynecologist and the obstetrician practicing should make it a protocol that if not every trimester, but once in a antenatal checkup, every patient should go through a urine checkup and a KFT report so that we at least have a baseline report. Because many a times we find that there are patients who are already chronic kidney disease, but they never knew. And throughout the pregnancy, chronic kidney disease was not picked up. And finally, we find that it kept on worsening, and now the patient is dialysis dependent when the disease is diagnosed. So, number one is obviously the antenatal checkup, obviously, for the existing kidney function, for the baseline kidney function. Number two, as ma'am have already explained very beautifully, that is the response team and a shared uh, work as a shared work of both nephrologist, obstetrician, neonatologist, and an intensivist for management of such patients who have landed up in ICU after cesarean section or after this. And the next is also very important. That is my third point. That is a post when the postpartum AKI settle down or it does not settle down, most of the patients who are dialysis independent now don't often miss the follow-ups. So what happens is they'll be coming to you in their next pregnancy with the similar complaints in around second trimester, and we don't know what happened in between. So obviously this postpartum AKI follow-up should be one thing which should be further strengthened up. And the last one is multidisciplinary protocols. For example, I'm talking about atypical HUS, which is very commonly seen in tertiary care centers, but most of the time it is so much delayed in being diagnosed that nothing much cannot be done because the platelet counts are already started improving and now the kidneys are permanently in acute cortical necrosis. So most of the hospitals are already having such response teams or rapid diagnostic protocols so that such patients should not be missed. And as soon as they come to you, they should be diagnosed and the treatment should be started as soon as possible. Thank you so much.
Thank you, Dr. Mansi. So the crux of all this panel discussion is likely that women often seek medical attention late because of the various responsibilities of the family, their illiteracy, and their dependency on a male member of the family. So by the time they come to us, they mostly have advanced CKD or they have to be put on dialysis. So main thing that can overcome all this is timely referral and screening for, which is done for these women in rural settings. With this, I would like to thank our chairperson, Dr. Namrata, and all the esteemed panelists for actively participating in this discussion. Over to you, Dr. Medhavi, to take the proceedings further.
So thank you so much. So as we come to the end of this wonderful session, I would like to express my heartfelt thanks to everyone who participated so actively. And I'm deeply grateful to Professor Urmila Anand ma'am, who has been a constant pillar of strength to all of us. This program wouldn't have been possible without her support. My sincere thanks to Swaranjit Kaur ma'am, who was always just a phone call away and extended her full support to this program. I would also like to thank Dr. Anupama Kaul ma'am for her support and sharing her activities and for guiding me whenever things became challenging. A special thanks to Namrata ma'am, who has truly been the backbone of this program, and despite her family commitments, she was always available to guide me. In fact, the idea for the panel discussion was hers. Thank you, ma'am. Thank you so much. I'm also very thankful to Dr. Jasmine for her such excellent moderation of the panel discussion. Thank you for accepting the responsibility even at the last moment and handling it so beautifully. My sincere appreciation to all our young and dynamic nephrology colleagues from different parts of the North Zone who readily accepted the invitation and shared their valuable perspectives and experiences. Finally, I would like to thank Dr. Swalata ma'am for giving me this opportunity and for believing in me. And if I have unintentionally missed mentioning anyone, please accept my sincere apologies. And thank you once again to everyone for making this session so meaningful and successful. Thank you. We would now end this North Zone session.
Okay. At the end of North Zone, it was very wonderful presentation by Medhavi and her team, and the importance of female health, which they daily they face in North regions. We also face here, and the panel discussion was extremely fruitful and extremely engaging. And thanks to Jasmine and Namrata for organizing that, and all the works from North was very good and very engaging. And thank you, Medhavi, for bringing up all these things here. And
Thank you, sir.
I will move on to Telangana chapter. Dr. Priya, the stage is yours.
Thank you, Dr. Saivan. So, a very good afternoon, everybody. So, welcome to the Women in Nephrology Telangana State Chapter activities. So, I'm Dr. Priya. I'm a Secretary for WIN Telangana State Chapter. I'm Assistant Professor of Nephrology at Osmania. So, now I hand over the session to Dr. Payal. She's here.
Hello. So we'll first start. I would request Dr. Kiranmai ma'am to please deliver her opening remarks on this WIN Telangana WKD activities, please.
Good afternoon all. Welcome to the WIN Telangana chapter sessions. Since afternoon, we have been celebrating the World Kidney Day theme of kidney health for all. Care for the people and protect the planet. We have been listening to the various activities from different state chapters. Very interesting sessions and interesting snippets as well. So from Telangana, we have two sessions. As you all know, green dialysis is an emerging field which aims to keep the kidney care environmentally sustainable, at the same time maintaining an excellent patient outcomes also. And the dialysis therapy we offer to the patients has huge burden on the environment because it utilizes high water, energy, and generates high medicinal waste and carbon emissions. So environmental optimization of this dialysis therapy is crucial. So this optimization needs spanning from the production to the transplantation, transportation, and application and the waste management also. So in order to decrease the burden on the environment, we have to focus on early kidney disease diagnosis and slowing the disease progression as well. So increasing the access to the kidney healthcare and optimizing the non-dialytic kidney failure therapies are very important in achieving this initiative. So the personalization of the dialysis timing and uh, incremental dialysis adoption are some of the methods to reach this sustainability. So we have two sessions where we will be discussing the ways and means of achieving this environmental sustainability. Over to the speakers and chairpersons.
I would like to invite the chairpersons for the first session, Dr. Manisha Madam, Dr. Manjusha Madam, and Dr. Rama Madam. We have Dr. Harika and Dr. Manusha, who will be discussing on eco-friendly kidney chart.
Thank you so much, ma'am. Our discussion is on a real-world nephrology situation. We often talk about dialysis adequacy, but we rarely discuss the environmental cost of dialysis. For example, as we all know, a single session of hemodialysis utilizes nearly 500 liters of water, which amounts to around 45,000 liters of water per person per year. So our official portal of Pradhan Mantri National Dialysis Portal shows as well 31 lakh patients are availing dialysis services, which amounts to around 410 lakh sessions being held per year, which is a quite heavy price being paid by the environment to sustain our life. The question lies here is, can we make dialysis environmentally sustainable without compromising on patient care? Over to Dr. Harika to give us some insights regarding this.
Thank you, Dr. Manusha. The kidney care and climate change influence each other in a two-way circle. The kidney care practices, particularly dialysis, contributes to significant amount of carbon footprint. Therefore, green nephrology practices are essential. Green nephrology is environmental sustainable approach to kidney care. Its aim is to reduce the carbon footprint of nephrology practices while maintaining the high quality patient care. The carbon footprint refers to total amount of greenhouse gases released into the atmosphere due to human activities expressed as carbon dioxide equivalents. These gases trap the heat in atmosphere and drive the climate change. These are the various parts of the carbon footprint.
Oh, okay, Dr. Harika, what are the things in our dialysis unit you think can contribute to this carbon footprint?
Yes, of course, activities such as water consumption for dialysis preparation, RO purification, energy used for running dialysis machines, RO treatment, etc., waste generation from plastics and disposables, chemical usages, and biomedical waste processing, emissions occurring during manufacture of the dialysis, and machinery transportation, which is often overlooked, all contribute to the carbon footprint, highlighting the importance of the sustainable medical practices. Patient transport can contribute to up to 30 to 40% of dialysis carbon footprint in some regions.
Okay. Is the carbon footprint same for both hemo and peritoneal dialysis?
Yes, there is a difference. Dialysis is a water-intensive therapy. A standard 4 hours dialysis session requires around 500 liters of water, mainly for dialysis preparation, RO reject water, and machine cleaning, totaling of 1500 liters per week of thrice weekly hemodialysis. In contrast, peritoneal dialysis uses comparatively less water, although the patient directly uses only 8 liters of dialysate per day. When we include manufacturing losses and disposable related water for plastic bags, the total water footprint comes to around 120 liters per day and 840 liters per week. Therefore, peritoneal dialysis has lower water footprint compared to conventional dialysis. Dialysis also consumes significant electricity. In hemodialysis, power is mainly used by RO water system and dialysis machines, averaging about 6.2 kilowatt hour per session. whereas peritoneal dialysis generally uses less power. But automated PD still consumes about 0.07 to 0.1 kilowatt hour. Thus, energy consumption in dialysis contributes to its environmental footprint. Dialysis also generates significant amount of the medical waste. Hemodialysis produces about 2.5 kg per session of HD, totaling about 7.5 kg per week, while peritoneal dialysis generates even more, about 12 kg per week due to daily exchanges. A large proportion of this waste is plastic, especially PVC, highlighting the environmental impact of the dialysis care.
Dr. Harika, did we calculate waste being generated at our HD unit?
Yes, we have conducted one study at Usmania. A prospective study was conducted, evaluated biomedical waste generation in hemodialysis over 1 year with more than 21,000 dialysis sessions. Each HD session generated about 1.29 kg waste per patient.
That's a huge chunk. We understood the problem, but what about the solution? From a clinician's perspective, where do you think, Dr. Harika, we can realistically conserve water and reduce waste without compromising patients' care?
Yes, there are strategies to reduce the carbon footprint in dialysis unit. This can be divided into water and energy conservation strategies and waste management strategies. Water conservation strategies has two main targets. One is to how you reuse and recycle the dialysate and RO reject water, and second is how to optimize dialysis prescriptions, which can decrease overall water consumption. Hemodialysis produces high density wastewater which is rich in salt and uremic toxins, but the studies show it can be safely reused for irrigation, landscaping, and sanitation. By monitoring the TDS conductivity and SAR, this water can be repurposed, reducing the dialysis wastewater. These are the images depicting the aquaponics and horticulture.
I have a doubt here. Can we use this reject RO water for dialysis again by retreating it?
Yes. Instead of wasting RO reject water, dialysis units can recirculate a portion of it back into the RO system, allowing it to pass through the membrane again and improve the water efficiency. A conductivity meter ensures safety by stopping the recirculation if mineral concentration becomes too high. Additionally, the unused permeate can also be reused in a closed loop, significantly reducing the water wastage, supporting more sustainable practices. And we also adjust the dialysis prescription by lowering the dialysate flow and increasing the dialysate temperature. By lowering the dialysate flow, we can reduce the water consumption from 120 liters to 96 liters per session.
Dr. Harika, I would like to interrupt here. Are we not compromising on dialysis efficacy by reducing the dialysis flow rate in order to conserve water?
No. An increase in dialysate temperature by 1 to 1.5 degrees centigrade is believed to increase diffusion by an increase in Brownian motion and decrease in blood viscosity, decrease systemic vascular resistance, resulting in better perfusion and increased urea clearance. This was a pilot crossover study from India evaluated eco-friendly dialysis strategy by increasing the dialysate temperature and reducing the dialysate flow from 500 to 300 ml per minute. This approach can reduce the dialysis water consumption by 40%, making dialysis more sustainable without compromising the patient safety. One more method is sorbent dialysis technology, which regenerates dialysate using a sorbent cartridge, reducing water use from 120 liters to 6 liters per session, lowering the power needs. One such example is artificial variable kidney. While environmentally promising, its main limitations are high cost and cartridge disposal. This is a sorbent dialysis technology.
Yeah. That's an effective way to conserve water. But do we have any similar methods to conserve electricity as well?
Yes, the dialysis unit can safely reduce the carbon footprint by shifting to renewable energy resources like solar, wind, and hydro. The effective dialysis waste management starts with 4R approach, that is reduce, reuse, repair, and recycle. Reduce can be done by using incremental dialysis, minimizing the contaminated waste, reusable materials, and proper waste segregation. Dialyzer reuse helps in reducing the plastic waste by up to 5 to 30 times. Reuse can also extend it to items like bicarbonate cartridges, plastic bottles, and tourniquets. This is a study showing the dialysis generates large amount of PVC, rich in clinical waste that is often incinerated, causing harmful release of the toxic fumes. Effective strategies include proper waste segregation, recycling, packaging, and reducing and replacing the PVC-based materials. This is regarding dialyzer reuse. By reusing a dialyzer up to 8 times, we can save up to 126 dialyzers per patient per year. In a 100-patient dialysis unit, this can reduce around 3.5 tons of waste annually.
Dr. Harika agreed that it will cut down the waste being generated, but by promoting the dialyzer reuse, are we not subjecting the patients at increased risk of infections?
Not necessarily. When we reuse follows strict sterilization, integrity testing, and a single patient allocation protocols, studies showed no increased risk. Instead, it safely reduces the cost and biomedical waste, making dialysis more sustainable. The non-contaminated plastics, paper, and cardboard can be recycled into plastic pebbles and bricks, whereas contaminated plastic wastes are usually not recycled but can be sterilized and shredded for use in construction materials like concrete. These are the various dissembles and soft raw materials that can be obtained from the old dialysis machines, which can be recycled for further purposes. This technical cycle contributing to circular economy where they transform waste into resources and promote a sustainable regenerative system. This is an environmentally sustainable dialysis unit containing solar plates, greenery, well-ventilated rooms, waste segregation, electrical vehicles, etc.
Wonderful. That sounds very ideal. But in a busy dialysis unit in India, do you think it is economically feasible for us considering the limited resources we have?
That's a valid concern. However, many eco-friendly dialysis practices are actually cost-saving in long term. This can actually save money. Practices like dialyzer reuse, RO water recycling, and energy-efficient machines reduce the waste, lowers the cost, and make sustainable dialysis feasible in resource-limited settings like India.
Okay, what about PD then? Can we make PD also environmentally sustainable?
Peritoneal dialysis may generate significant plastic waste, but it remains one of the most sustainable dialysis options, promoting home therapy, reducing the patient travel, optimizing the packaging, and improving recycling PD plastics. We can significantly cut down the environmental footprint by delivering effective kidney care. This slide highlights the annual carbon footprint of different dialysis modalities. In decreasing order, in-center dialysis has highest environmental impact, followed by home dialysis, followed by APD, followed by CAPD.
Do we have any novel methods to minimize dialysis wastage in PD?
Yes. There are innovations like LN Medical Affordable Dialysis System and automated wearable artificial kidney, which works on the sorbent-based technology in generating PD fluid with minimal waste water. These are the 10 affordable action plans. And to conclude, we do not inherit the earth from our ancestors. We borrow from our children. Thank you.
Rightly said. Very rightly said. Thank you so much, Dr. Harika, for enlightening us with various eco-friendly aspects of that. It was a wonderful topic.
Thank you, Manusha and Harika. That was a very engaging chat. I request the chairpersons to provide their valuable comments on the same.
Yeah, so thank you, Harika and Manusha. Well done. And I mean, it's very nice that this year's theme focuses on green nephrology apart from the patient care as well. And I think that these talks are important. And once having heard these talks, our duty is to next day put our postgraduates in the dialysis unit, give them some sort of exercise there for calculating the waste generation, and let them think of some innovative methods to reduce the water biomedical waste as well. So only talking about it won't help, but I think we should look around us in our units as well, and probably we can at least start by reducing that dialysate flow rate, which is easily doable, like getting it down from 500 to 400, which we may not do. So that's important, and increasing the temperature, that also helps, because that is doable, doesn't need any extra equipment or anything at all. So I think we should start focusing on this. So thank you. It was very well presented, and I think people have greatly benefited from your presentation.
Thank you.
Thanks, the team who has presented about the discussion regarding the environment safe dialysis. It was very well presented. The strategies are very well known, but the challenge is in implementation of it, whether it's at the center level or whether it's at the community level or whether it's at the level of the policy makers. Today only I had just gone through the Guardian post where they said that the air pollution has decreased by about 9 to 20% in cities like Beijing, London, and San Francisco. So policymakers have also got to focus on the environment. As we had rightly placed the theme this year to be on protecting the planet, we need to safeguard the planetary health by various measures that we can take at our level. Dialysis centers, of course, with our centers in Telangana being humongous in numbers, it's not easy, it's extremely challenging, but then putting it into the policymakers' minds that this is equally important is the one which we need to raise it upfront through, so that we do not have much of a pollution, and we foresee that the futuristic setup of the dialysis units at least are guarded with the environmental safe measures so that the burden of the biowaste generation decreases over a period of time. Thank you. Thank you so much.
Thank you, Dr. Harika and Dr. Manusha. That was a very beautiful presentation. You not only discussed the causes, but also the solutions for reducing the footprint. So while we do follow whatever possible, I think one step is that we can increase CAPD. We can give a proper push to CAPD wherever possible, as it definitely reduces the footprint compared to hemodialysis.
I thank all the chairpersons for those really valuable and practical insights. Now we move on to the next session where we'll just have a brief overview of the WIN Telangana WKD activities, which will be presented by Dr. Snigdha.
Good evening, everyone. Am I audible? Firstly, I thank WIN India Telangana chapter for giving me this opportunity. I'm Dr. Snigdha, Assistant Professor from Nizam's Institute of Hyderabad. I would like. Are my slides visible?
No, not now visible.
Firstly, we will start with the Team Usmania Hospital. They have conducted a kidney awareness rally, which was headed by Dr. Manisha Sahai ma'am. We can see the enthusiastic participation from the residents, dialysis technicians, nursing staff, and holding the handmade posters. And this rally was conducted throughout the campus, in the campus premises of the Usmania Hospital. And even the administrative staff also had participated in this, and we can see the signs made in native languages like Telugu and Hindi, so that patients can read them and understand what was being suggested. And this is the group of the technicians and nursing students who were involved in the rally, holding the handmade signboards in all the different languages. And following this, there was a skit organized by the team. The skit played by the dialysis technicians and resident doctors together. And it opens with the patient being brought by a family member in a critically ill condition to the doctor. And the patient explains his illness to the doctor, and he explains the nature of long-standing illness. And the doctor thoroughly examines him, understands the illness, and then she explains him how it would have been easier if the presentation was earlier, and how simple it is to detect the kidney disease in the earlier stages. that would avoid the presentation in the later stages, and the resident doctor taking over and explaining the nature of kidney diseases, need for early interventions, and community-based screenings.
Snigdha, sorry to interrupt. Your slides are not moving. It's stuck at.
Sorry, ma'am. Is it moving now?
It's kind of shady. It's not full, Snigdha. Yeah, now it's there. It's actually a little lagging behind. Yeah, the slides.
Okay. This event was followed by a quiz program. All the broad specialty departments like obstetrics, gynecology, anesthesia, general medicine had participated in the quiz, and there was very enthusiastic participation from these residents, and the prize distribution was followed the quiz. And there was drawing competition for the dialysis technician students. We can see the handmade cardboard kidneys.
We can't see Snigdha. I think you are stuck in that rally only.
This only second slide we are able to see.
Ma'am, are you able to see now, ma'am?
The slide is there, but it's stuck at second slide. The second slide of rally.
The rally only is there, yeah.
Can you stop sharing and restart resharing otherwise?
Yes, ma'am. Ma'am, is it visible now?
Yeah. Can you start now? Yeah. Just go on first. Yeah. We are at the first slide now. No, it appears blank. Yeah. Yeah, go on. We can see, but just go on. Yeah, we're still seeing the rally slide. Yeah, next up. Can you scroll through once? Fast, because the slides are coming up little slower.
Yes, ma'am. Are they moving now, ma'am?
They're moving, but they're very slowly moving. So we just still see the rally slides only.
Otherwise, you can just go into not just slide sharing mode, other mode, so that you can select whatever you want.
Are you able to see, ma'am? No. Are the slides moving?
They're moving. Yeah, they're moving, but slowly, very slowly.
Keep on moving. Keep on moving.
Keep on moving. Keep on moving. Yeah, this is that technician's kit wala. Yeah. You go on otherwise.
Yes, ma'am. Ma'am, should I share it to you, ma'am?
Yeah, please do that. I'll just try.
Yes, ma'am.
Meanwhile, you can go on. You just share it with me and then you can go on. I'll try to. Sorry for that, everybody.
Dr. Priya John, ma'am, she was live on All India Radio Vivid Bharati on the day of World Kidney Day, enlightening the community with her insights. And next, moving to the Gandhi Hospital team, the awareness program was planned over a period of 4 days. The first day was the awareness program for final MBBS students, started with the inauguration by Manjusha ma'am, principal ma'am, vice principal ma'am, and superintendent ma'am, followed by talks by the faculty regarding the kidney health awareness and this year's theme, Saving the Planet and Sustainable Practices, was attended by all the students, dialysis technicians. And following the next day was the rally in the premises of the Gandhi Hospital. This included the nursing staff, paramedical staff, dialysis students, and residents of the nephrology department. Here we can see the technicians enthusiastically preparing the signs to participate in the rally. And we can see the faculty and residents along with the technicians walking throughout the campus at various places. And the third day was the OP screening program conducted for the screening of kidney diseases in 100 women with the point of care device inaugurated by the principal ma'am. And here the patient details are being noted, and the blood sample for creatinine and urine sample for albumin creatinine ratio is being collected. And the last day of the awareness program was interaction with the first and second MBBS students. Was inauguration session followed by the addressing of the crowd by superintendent ma'am, vice principal ma'am, principal ma'am. And then there was a talk regarding the kidney health and sustainable practices of green nephrology, which was attended by the first and second MBBS students and various paramedical students. And later there was memento presentation for the nephrology residents for their commendable and exemplary services in the department. And the session ended by the group photos and cake cutting. And now next, let's move on to the events by Nizam's Institute. So we had 4 sessions. The first was a mini dialyzer workshop, which was organized in association with the service provider Niprotein. We had international technical expert to guide us with the manufacturing and processing of the dialyzer making. So we can see all the residents as faculty and nursing staff participated in the event, and all the mini dialyzers are carefully rearranged, and the parts are arranged, and the cutting and processing of the dialyzer was explained on hands-on. This was followed by the catheter insertion hands-on program for the residents and technicians. This was for the second event was on 27th, the dialysis technician session on green nephrology. We had participation of about 80 people in the session, and the first session was by Dr. Payal Gagar ma'am on clinical green dialysis practices, and the second session was by Priya John ma'am on technical green dialysis strategies, followed by a quiz session by me and Kirtana ma'am. And we had the winners of the quiz announced. The prize distribution program is awaited. And the third session was done on 1st of March in diet and health in renal disorders. We had help from the dietitians across the Hyderabad from various institutes. Moderator was Rama ma'am from Usmania Hospital, and the first talk was nutrition in non-dialysis patients in the early stages of kidney disease by Sunita ma'am. She's a dietitian and head of the department in Yashoda Hospitals, and this was shared by Manisha ma'am and Deepti ma'am. And the second session was nutrition in dialysis patients by Radha ma'am, who was a dietitian in AIG hospitals, chaired by Swanlata ma'am and Anuradha ma'am. And the third talk was nutrition in transplantation patients by Malishwari ma'am, chief dietitian in Star Hospitals. This included the nutritional requirements in immediate post-op period, failing graft, chronic rejections, and the session was all moderated by Ramapriya ma'am. There was a department meetup on implementation of the strategies, how to effectively take forward the initiative of green nephrology and sustainable practices in the department, and appreciation of the faculty and residents for their services in the department, unwavering dedication. And finally, this is Dr. Bhavya, alumnus of the Osmania Hospital. Currently, she works at TX Hospital. She has conducted a patient awareness session in her hospital, addressing general doubts from the patients and their family members regarding the myths of the kidney disease. And thank you.
Thank you, Dr. Snigdha. Chairpersons, any questions?
Thank you. Thank you so much. I think some effort should have been done to share the PPT little properly, because we could not get to see the Nizam's contribution and completely our contribution. Anyways, nevertheless, the tech glitch and all this. But I think I mean, she has shared the Win Telangana activity as well, which we had done recently. So lots of activities that have been done on behalf of Telangana chapter, but scope is there for us to reach the public in a little more way. And congratulations and kudos to all the leads who have done an excellent job in spreading the awareness about kidney diseases. So thank you so much.
Yeah, thank you, Snigdha. So from my side also, I mean, we wish to see the NIMS and other hospitals also. It was lagging back. So it's okay. I mean, can't be helped. Maybe sometimes these things happen. But congratulations and kudos to the Telangana team for putting together all this work.
Thank you.
I think special effect was put on the slides. That's why it is going slow.
Yeah, we're so, very sorry for the inconvenience. I think it is due to the technical glitches. Normally, animation should also be, we should be able to play, but I think there's some problem there. So I think that is the reason why we are not able to see the slides going on as per the animation timing and all. So very sorry for the inconvenience. So we are very grateful for all the activities organized by women nephrologists in the state of Telangana. So we had a great week last week. We started off like with dialysis technician awareness program, online webinar on nutrition in CKD and transplant patients and dialysis patients. And then we went ahead connecting activities in our respective hospitals, not only in government sector hospitals, but in many private sector hospitals. We have seen many awareness talks, videos, and many programs going on. So we are very happy that many such efforts are being put by the nephrologists of the state to get awareness to the common public. So I really thank you, each one of you, the chairpersons, Dr. Manisha Sahai, Dr. Mandusha ma'am, and Dr. Rama, Dr. Payal for moderating the session, and Dr. Swanlata ma'am for always being there, for all the encouragement behind and supporting us in every thing we've been part during this World Kidney Day. And now to conclude, we understand that we are at this unique intersection as nephrologists of delivering quality patient care and at the same time being responsible for our planet. So it's our duty to deliver the quality patient care as well as make our every effort to make our dialysis care environmentally sustainable. It all starts with a small change. So let's all pledge today that we all start off with that tiny changes, whatever we can do in our dialysis units. So thank you, everybody.
Thank you. Bye.
That's a great presentation by Telangana team and a great discussion between Manusha and Harika. And Snigdha, you have presented very well. And because of you, I could see my Usmania hospital. It's long time and my teachers and mentors for long time. Thank you. And we'll move on to Ranjini Muthu, madam, and for Tamil Nadu chapter. And I hand over the stage to Ranjini Muthu, madam.
Thank you, Saivani. Very warm greetings from Women in Nephrology, Tamil Nadu. On the occasion of World Kidney Day 2026, which is the theme is Health Initiative, Kidney Health for All, protecting the planet and taking care of the patient. This year, Women in Nephrology, Tamil Nadu has chosen to speak on Green Nephrology Drive, which is much talked about and very much needed in this hour, to adapt to various ways to reduce the footprint of hemodialysis and to minimize the environmental impacts of treatments like dialysis. to promote water and energy conservation, waste reduction, and preventive strategies to delay the disease progression. It was pioneered by Dr. John Agar, the pioneer of Green Nephrology Drive. He's a Australian nephrologist who has done great work on this field, and probably we can replicate many of his innovations, and we can put into practice. To elaborate on this, we have 3 sessions today from Tamil Nadu. And over to Dr. Radha Vijayaraghavan, who will moderate the sessions on all 3 and will preside over. Thank you for the opportunity. Thank you. Over to Dr. Radha.
Good evening, distinguished delegates. So from Tamil Nadu, we have short topics on the topic of green nephrology. So the first topic would be early detection and retarding the progression of kidney disease as an eco strategy. So any waste that is not generated is not a waste at all. So how do we prevent CKD and look at it as an eco strategy? For this, Dr. Maiviri Selvi will be delivering the talk, and the chairpersons would be Dr. Muthu Jayaraman and Dr. Anita Jagannath. Dr. Muthu Jayaraman does not need any introduction to this audience. She is the matriarch of our women in nephrology. She has many first women achievements. She was the first women medicine PG, first women nephrologist in Tamil Nadu, and she is the guiding force and light for all our activities, and her enthusiasm is unmatched. So she takes a lot of interest in all our activities and also tries to be physically present there. And so I invite Madam to be the one of the chairpersons. The other chairperson is Dr. Anita Jagannath, who's a senior nephrologist at Guest Hospital, Chennai. Madam is an excellent clinician and distinguished academician, and keeps herself update. She was also a consultant at Railway Hospital and is my teacher and mentor. So it's my honor to invite Dr. Anita to be one of the chairpersons. I hand over the podium to the chairpersons to introduce the speaker, and I invite the speaker to deliver her session. Thank you. Dr. Muthu Jayaraman, Madam, can you please introduce the speaker? If Madam is not able
Logged
to
in yet.
log in, Dr. Anita, Madam, can you please introduce Dr. Maiviri Selvi?
Dr. Maivili Shelby is an apt person to deliver this lecture. She's a MD student from Madras Medical College, and she did her DM from Madras Medical College again. At present, she's working at Apollo Specialty Hospital, Trichy, and she's an excellent orator. I'm sure that she will make enough justice for the topic. And her main interest is on renal transplant. Thank you. Dr. Maivili, please.
Thank you very much for Vin to for giving me this opportunity. May I start the talk, ma'am? Can you see my screen?
Yes, it's visible.
Yes. So as we all know, CKD is a silent epidemic, and 1 in 10 adults worldwide has some kind of kidney diseases. When ESRD develops, dialysis becomes life-saving, and as we all know, it is one of the most resource-intensive therapies in modern medicine. So this raises an important question. Can early detection and slowing CKD progression serve not only as a clinical strategy, but also as an ecological strategy for sustainable health care? So this slide shows the environmental impact of dialysis, which I think you all have been listening since the start of the day. About 3.36 million people worldwide receive dialysis.
Maivi has become inaudible. You're muted.
Can you hear me now, ma'am?
Yeah.
It has become, it has a large environmental footprint due to water use, energy use, plastic waste, as well as transportation, and due to the pharmaceutical use. So plus it has a massive water consumption. Roughly 18,700 liters per year per patient is required for a patient undergoing hemodialysis. And out of this, RO systems waste 60 to 50% of water. And as we all know, the hemodialysis requires high energy consumption, as well as roughly 2.5 kg per session waste is generated per patient per session. Also, it has a major carbon footprint to the estimated ton of 3.8 tons CO2 per patient per year in UK and 10.2 tons of CO2 per patient per year in Australia. So when we come to peritoneal dialysis, it also has disadvantages, but in compared to hemodialysis, it is less, but it also produces significant amount of, it also weighs significant amount of water, as well as it also emits major carbon footprint. So the above slides were shown to show the impact of the hemodialysis and the peritoneal dialysis waste on the environment. So we come to the point why early detection of CKD matters. It is often asymptomatic until advanced stages. So the simple screening tool like urine albumin and serum creatinine and EGFR calculation and BP measurement is enough to diagnose early stages of CKD. All these things can be done in a simple PHC setup. And the high-risk population like patients with diabetes, hypertension, elderly, family history of CKD and obesity should be thoroughly screened so that the early stages of CKD are detected. So plus how
Selvi, please go to slideshow, Selvi.
Where's the slideshow? Can you see one? So the intervention that slow the CKD progression or like BP blood pressure control with using RAS blockers, glycemic control using SGLT2 inhibitors, and also proteinuria reduction by means of RAS inhibitors, SGLT2 inhibitors, and newer mineralocorticoid receptor antagonists, and also other interventions which slow CKD progression are those patients who has developed AKI, both hemodialysis requiring and non-hemodialysis requiring, and those who have reached baseline and those who have not, those who had partial recovery, both should be followed up thoroughly for the future development of CKD and ESRD so that the patients we can retard the progression of CKD. So the other lifestyle and preventive measures which can be taken up to detect or to slow the CKD progression or to exercise should be encouraged to at least 40 minutes per day for 5 days a week, and plenty of fluids should be taken, and salt restriction and healthy diet should be encouraged, and weight management in obese people, and smoking cessation and avoiding alcohol, and to avoid nephrotoxic drugs. So the golden 8 rules to protect the kidney should be more advised to the patients. And also early nephrology referral whenever needed, and even small reductions in EGFR will go a long way in delaying the dialysis. So what are the preventive strategies that can be, which we can do to achieve these? So the grassroots level programs, already this is somewhat done in Tamil Nadu at the level of PHC. So there is a separate program for this non-communicable disease screening. So it is thoroughly screened. The patients are thoroughly screened for diabetes, hypertension, and nowadays they are also thoroughly routine for urine albumin and creatinine also. These programs, still more emphasis can be given to this program. They can be integrated. So it is not done as a part of CKD prevention, but it is done as a part of non-communicable disease prevention strategies, and patients are also checked whether they are taking antihypertensive drugs properly or not. This could be more improvised and so to prevent CKD also. And adequate training of health personnel regarding the increased incidence of CKD and its preventive measures should be given. And also we should train the non-nephrology people who come into contact with these patients at the first instance, like they come to us only in the last stages. So we should train the MBBS persons who happen to who work in the PHCs, and also the physicians who work in the PHCs about seeing a simple urine routine and creatinine for every diabetes and hypertension patient, because we often see the patients being treated for diabetes for 5-10 years without seeing a simple creatinine. At last, when they develop creatinine, it would be around 5 or 6, and they'll say that they have never checked creatinine at all. So we should train the non-nephrology people, that is the basic physicians who come into contact patients at the first instance, that we should teach them the causes of CKD and how to diagnose it early, and early referral also. And also the most important other one preventive strategies might be to create awareness among general public regarding the CKD, its causes, and how it should be prevented. Like we should also emphasize on the adherence to diabetes, hypertensive medications, and also especially to like I work in a Delta area where the CKDU population is it is very high. So they do not know the importance of taking water while working in hot, humid conditions. So actually, we are trying to create an awareness program where we are going to have a pamphlet emphasizing all the preventive steps that they might take to prevent the CKD occurrence. Like they should properly take water while working in a hot, humid climate. They should not forego drinking water. And also, we should encourage research in organic farming so that the pesticide use may be limited because it is postulated as one of the cause of CKDU. And also another one novel idea might be, but this is already done. But before employment, even in government sectors or in, I think it is done in software, but I don't think it is done in other areas. Screening for diabetes, hypertension, CKD should be done. But of course, it should not affect their work prospect. If they are found to have any of the risk factors, like they should not, they should also get the work with governing laws, with proper governing laws. This before employment, the screening should be done so that they can, if CKD is there, it can be managed properly. And also awareness among children can also be created where textbooks regarding the incidence of CKD, the causes of CKD, how the prevention should be done, should be included in the school curriculum, probably written by a senior nephrologist, which might create more awareness. So what this benefits of early detection, as we all know, it reduces the incidence of CKD. These steps can reduce the prevalence of CKD, and also if CKD occurs, it can reduce the progression to ESRD, so that fewer patients might require dialysis, which might lead to lower health cost and reduced water and energy consumption. So prevention can create a sustainable health practice in nephrology. So it is CKD is a common but largely preventable and detectable disease. Screening high risk groups and follow-up is essential. Evidence-based therapies may slow disease progression, and preventing kidney failure protects patients' resources and the environment too. So in that sense, early detection of kidney disease is not just good medicine, but it is a responsible medicine for our planet. The greenest dialysis is the dialysis that never becomes necessary. Thank you.
Thank you, Dr. Maiviri. Dr. Muthu Jayaraman, Madam, has joined in. Madam, please give your thoughts, Madam.
Very, very good talk, Maiviri. You talk more about prevention. Can you hear me?
Yes, ma'am. Yes, ma'am.
Yes, Madam.
It's a very good talk, and you have given all about early detection and prevention. And I thought this was a talk about WKD theme, no? The protection of the planet, you're not taken into this. This topic is only about prevention and progression of the kidney disease. Am I right?
Yes, ma'am.
So how else? And can we do camps and then make awareness of kidney disease is equally important, no? Amongst the common people, leave alone nephrologists. How can we do it in our setup as women in nephrology group? In what way we can make the awareness of kidney disease in general public? Can you explain on that?
We can keep camps actually. We can screen for diabetes, hypertension, and simple urine test, blood pressure, and also woman-related things we can discuss. Ma'am, we can keep and we can have we can have a pamphlets. We can distribute the pamphlets also. We can have special camps. Like we can create some memes or some social activities.
So, and also important in diet is an important part plays in taking care of CKD and its progression. What way we can impress the general public about diet, less salt, less sugar?
Yes.
In what way we can do that, maybe?
Like salt restriction must be emphasized. We can ask them, like what I do simply in my practice, who comes to me is that I tell them that to avoid extra salt foods like all those appalam and pickles you have to avoid. If at all, if you use rice and kolambu, you just avoid salt in one of those. You don't put salt in your rice. You put salt only in the sambar, so that you can reduce the total intake like that. And also we should advise them, if non-diabetic, we can advise them to make more, we can advise them to take more fruits.
Another way is to, when the patient come, the accompanying people, we have to tell them also the importance of less salt in our diet, and also in a diabetic nephropathy patient, we have to tell the accompanying person. Very often, the obese person who brings a daughter or brother or sister brings the patient, they don't know they are also prone for the same condition. So it's equally important for us not only tell the patient what to do, and also the accompanying person to do what to do, how to prevent the onset of diabetes or to postpone it, and the diet instruction for the whole family. That's one way of, we can't be doing camps at least once a year, we are trying to do it. And this way I think we can educate the people about the awareness of kidney disease and the causes of the kidney disease, how reduction in the weight, exercise, taking a lot of water, all the 8 what you said are important in their life. And that is one of the good way to prevent, to make awareness. Next thing is the protection of the planet is another one. It's a part of the WKD theme. So how can we protect the planet? In what way? The time over. Can you explain?
The hemodialysis and peritoneal dialysis creates more damage, because the water that is required for hemodialysis per session is roughly 120 liters. So if we take into account the priming as well as the rinsing, everything, and reuse, it amounts to around 500 liters per patient per day per session.
150 liters, I think.
Yes, ma'am. 500 liters it is used. If you take into account the rinsing, priming, and reuse everything. So for a year, it takes for a patient 17,800 liters of water is wasted. And also, when you take dialysis, for per session, to run a dialysis unit, it takes about 6.2 megawatts of energy also. And also the plastic materials that the dialyzer is made of is also disposed. Nowadays, in fact, we are going towards, from reuse, we are trying to use single-use dialyzer. So for our convenience, because we want to prevent the transmission of HCV, hepatitis B. So we are moving, even in government setups, we are trying to move from reuse to a single-use dialyzer, which might be beneficial for the patient, but it is definitely more harmful to the planet.
For the system, environment, yeah.
Wasted. So these things can be prevented if, ma'am, am I audible? So if we delay the strategy, if we identify the high-risk population earlier, if we put all the strategies to delay the progression of CKD to ESRD, we might delay the dialysis of a patient by 5 to 10 years, so that which may have a huge eco-friendly action on the planets. And also the medicine.
Do you think, 1 minute, do you think the single use will reduce the water use? Single use of the kidney? And it will increase the plastic wastage.
Ma'am, the plastic waste, the water waste is usually like when you use single use, the reuse alone maybe less, ma'am. But anyway, we have to rinse, prime, and the water may be useful, a little bit lesser can be used, but still the plastic waste will be more.
You have to devise ways and means of reducing the reusing the water waste, the water, and also reduce the plastic wastage, and use electricity from solar power rather than the regular electricity. I think it's a very nice talk. Any other people on any question you can ask.
Thank you for those words of wisdom, madam. Dr. Anita, the other chairperson, do you want to share some thoughts, madam?
That was an excellent talk. Yes, definitely, because we are in a nation which is progressing, and we are neither a fully developed nation or a developing nation. We are in between, so we got to manage both protein, calorie, nutrition on one side and obesity on the other side. The other day, in a talk by Madras Medical College, Dr. Balasubramaniam insisted on free air pollution. That's a major important point. He said he showed evidence of papers showing that air pollution can definitely harm the progression of kidney disease. So we should make legal um, uh, thoughts about it and inform the government that we should have a pollution free environment. That is number one. Number two, we can recycle the water use into our own hospitals and grow plants. The place where I am working, the entire garden is made out of dialysis reused things, and Dr. Ravi also has shown us a way where plastics can be reused. He melted the plastics and made it into pots and some decorative items, and those are being made by the patients themselves, and they are selling it and they are making use of it for their own dialysis. This is the way where we can recycle in our own way and try to make an environment which is always green. So this is very important, and especially as women, we should insist on abdominal obesity, which is a very, very important factor, which increases the renal vein pressure and therefore reduces the effective glomerular filtration rate. Therefore, always tell them about the abdominal girth and the increased abdominal circumference, which has got a major value in obesity. I think that can be added to. Thank you.
Thank you, madam. We will go to the next session. Thank you, Dr. Maiviri Selvi and the chairpersons. The next session is on peritoneal dialysis, a patient-centered and planet-friendly approach by Dr. Bobiti Deepthi. The chairpersons are Dr. Suganya Govindan and Dr. Beena Unnikrishnan. Dr. Suganya Govindan is a senior consultant pediatric nephrologist at Mehta Children's Hospital, Chennai. She is a well-renowned pediatric nephrologist, associate editor of BMJ Pediatrics Open, Global Public Health Leadership Fellow from the University of California, Berkeley. She is convener and lead in Indian Pediatric Renal Nutrition Task Force. She has a number of papers and publications and is very active. I welcome Dr. Suganya Govindan to chair this session. The other chair is Dr. Beena Unnikrishnan, Professor and HOD of Nephrology at Sri Mogambiga Institute of Medical Sciences, Kanyakumari. She is an excellent clinician and academician and takes part in all the academic activities of WIN. And I request both of them to chair this session. Thank you.
Thanks a lot for the very kind introduction, ma'am. And I'm really happy to share this session along with a renowned nephrologist like Dr. Beena Unnikrishnan. I take great pleasure in introducing Bobiti Deepthi, who's no new comer to this group. But she's an excellent and very enthusiastic young pediatric nephrologist from JIPMA Pondicherry. She works as an associate professor there. She's very interested in patient care, patient-friendly care, and also in nutrition and in many other activities of the pediatric nephrology community she takes part in. Particularly today, she's going to speak to us on how peritoneal dialysis is not only a patient-centered approach, but also a planet-friendly treatment for patients with kidney failure. So I welcome Dr. Bobiti Deepthi to give her talk.
Yes, can you see my slides? Thank you for that lovely introduction, Dr. Suganya ma'am. Are my slides visible?
Not visible, Deepthi.
Not yet, Deepthi. Can you share them?
Okay. Yeah. Now? Is it visible now?
Not yet.
Okay.
Not yet.
Okay, just a minute. Share the entire screen. Now?
Yeah. Just go to the screen mode. Yeah, done.
Okay.
Go ahead.
It's okay. So a very good evening to one and all, and thank you for this opportunity. Before me, only the Telangana chapter had already spoken very lucidly about the environmental footprint of dialysis, including both HD and PD. Dr. Harita and Dr. Manusha. So I'll be just complementing their talk and providing few extra points. Coming to a case vignette, so this is one of our patients who was diagnosed with us at the age of 1 year with infantile cystinosis, nephropathic cystinosis, and progressed to end-stage kidney disease by the age of 8 years. And the parents opted that the child be initiated on maintenance CAPD. So as evident in this diagram, PD being a home-based therapy, it was very convenient for her and provided the parents a greater flexibility and independence compared to hemodialysis. It also reduced their patient travel, and we know that PD definitely offers a lower infrastructure and the staffing needs are less. But what is concerning is the stack or pile of the Baxter bags that we can see behind the cardboard bags, lot of paper use. And this is the wastage from the single-use plastic PVCs and a number of non-biodegradable material which was being generated from PD. So when we say that PD is better than hemodialysis in terms of environmental footprint or the carbon footprint, we must also remember that there are some points of concern even with peritoneal dialysis. The carbon dioxide emission or the greenhouse emissions are definitely greater with hemodialysis compared to PD. And in peritoneal dialysis, the automated peritoneal dialysis would have a greater greenhouse emissions compared to the CAPD. It definitely is home-based and has minimal use of water and electricity. But then use of APD shifts this water use and the electricity to a domestic setup. The infrastructure is low, but then it also contributes to environmental harm. So how does this peritoneal dialysis contribute to environmental harm? To understand this, there's something called LCA or the life cycle assessment. Life cycle assessment basically refers to a method in which we try to analyze what is the environmental contribution or the carbon footprint of each method, be it peritoneal dialysis or hemodialysis, starting from the generation of raw material to its disposal. So when we say that the PVC bags are being generated or the polyethylene single-use bags are being generated, there are greenhouse emissions at the manufacturing level. Then we need these cardboard boxes which will require the forest to be cut down or the wood needs to be taken from there. The electricity is needed for the APD machines. And finally, the disposal of all this non-biodegradable material, because the healthcare sector waste is usually categorized as hazardous material and it becomes tricky how we dispose them. So using this LCA method, many people have tried to quantify how much does the PD contribute to environmental harm. So it contributes less than HD, but it is definitely significant in terms of electricity, in terms of water use, in terms of patient travel and also the transport of the raw materials to the patients. So when we talk about sustainable kidney care and what can we do to reduce this environmental harm created by peritoneal dialysis, there are some suggested methods which we can follow. One of the easy ones and one of the things that we as clinicians can follow is incremental peritoneal dialysis or decremental peritoneal dialysis. So what do we mean by that? It basically means that we need to prescribe the peritoneal dialysis very wisely. In incremental PD, what we do is we initiate the peritoneal dialysis only when the GFR has significantly reduced, or in the presence of residual kidney function, try to initiate at a later stage, but doing all this keeping in mind that we are not supposed to compromise on the health outcomes of the patient. And gradually, as the residual kidney function reduces, we can go on increasing the PD. So what happens when we initiate at a lesser than standard dose is that it helps in reducing the cycles, it helps in lowering the dialysate use and also the disposal needs, and it has cost benefits. Similar to incremental PD, as the patient's status changes or say requirement comes down with some initiatives like reduced weight or diet, we can always reduce the cycles. So either we can use incremental PD or decremental PD. These can have a good contribution to reducing the environmental footprint. Although we know that APD comparatively produces a higher carbon footprint, be it in terms of polyethylene production, use of electricity, water, but still reduced electricity can be implemented by using higher efficiency cyclers and renewable household electricity. So this table shows here that while APD per se generates 3000 kg carbon dioxide emission, when we use the incremental APD approach, it has almost become half. Other measures are optimizing the medication use. So wherever possible, we can try to de-prescribe the medications and come down on it. Only order what you need. So what we mean by only order what you need is do not overburden by ordering extra number of PD bags. Look at what is the clinical status, what is the compliance with the patient, and probably there may be some prescription changes. So, and what is the expiry date? So try and order whatever you need. Optimizing the use of virtual care and telemonitoring or the telemedicine. So this will reduce the patient travel part and the carbon dioxide emissions. So wherever possible, we can use virtual clinics and try to improve the adherence of our patient to PDs and at the same time contribute to environment. We can decentralize the blood sampling. There can be local PHCs involved for using the blood sampling. We can adopt water efficient manufacturing and prioritize suppliers which have the environmental certifications. This is something Dr. Muthu ma'am was talking about, adopt a planetary healthy kidney diet. So when we say planetary healthy kidney diet, probably a vegetarian diet, but at the same time ensuring that our patient gets the adequate amount of protein which is required for his state. Then steward use of PD consumables. PD consumables at present, be it polyethylene or the PVC bags, are usually non-biodegradable. So we can try and shift it to low carbon logistics. So Baxter in Australia, New Zealand has come up with systems where there is take back. So they take back all these bags and try to recycle into reuse into something else like be it raincoats or suit covers or other things. So we can substitute PVC and redesign these components for recyclability. And as this figure shows, it is the triple R, reduce, recycle, and wherever possible, try to recycle the eligible PD materials. So the principles of sustainable care in general fall under this 6 major headings: health promotion, which we have already discussed in terms of incremental or decremental PD, using virtual clinics, optimizing our medications, and improving access to kidney transplant. Overall, be it HD or PD, they have a greater environmental footprint compared to a child who can be transitioned preemptively into transplant. And try to streamline the deliveries, like something like regional dialysate production can be encouraged. And also the use of U-drain. So this is something interesting that I read in UK. There's something called U-drain, by which the PD effluent is directly drained into the plumbing system of their houses. So reducing the use of this single-use plastics. Reusable PD effluent collection reservoirs can be used. People have come up with new material, but the environmental footprint has not yet been adequately studied. Sustainability or waste audits can be conducted in each unit, like Osmania had shown very nicely that they did conduct in their unit, and they have tried to implement some changes. Reuse of the material into bags, raincoats, and recycling of the water of HD was also shown in the previous talk. Similarly, the single-use plastics of PD can also be recycled. And many emerging technologies include something called where the dialysate is regenerated locally using the sorbent systems. There is point of care dialysate generation, and using the sterile water distiller as well as the electrolytes, it can be generated at home, thereby reducing the traveling needs or from the manufacturing site to the patient home. So although this all sounds very ideal, but who are the people who can do it, and how are we involved? So when we say there are things in place, but it is a multifaceted approach, and many people have to be involved into this. We as nephrologists can be involved, PD nurses, dietitians are involved in this, but we also need patient advocates. We can we can start with talking something simple about climate change, and we can encourage our patients to talk about sustainable kidney care and ask them to question about what to do for this waste segregation. Then some centers like UK have a designated staff member talking about and taking care of these things, and they are designated as green champions. So maybe something like that we can introduce in our units. we definitely need support from the local authorities, the biomedical waste managers, the sustainability managers. And when we look at a wider scale, or the wider stakeholders are the machine manufacturers who can help in reducing the greenhouse emission, and the policymakers. Thank you.
Thank you. Thank you, Dr. Bobity Diti. It was a really great talk. I mean, you have really, being a pediatric nephrologist, I mean, you have your own problems, and adult nephrology is a different thing. I feel peritoneal dialysis, of course, it is considered to be a little eco-friendly compared to hemodialysis, but then we are still looking for that utopian age. Can we reach there? See, what I understand is whatever we do, there is, for anything you do, there is always a risk. Environmental impact is always going to be there. We know how our health is being interconnected with the climate change, the environment change, and especially the kidney health is being affected. Looking for an eco-friendly, I think it starts with the patient also. I think there should be a shared decision. We should be talking to the patient, what are the things actually. We should empower them also. It is very essential that they know what is really happening. We are holding a lot of talks and discussions and looking at it in many ways, but I wonder how much do they know. And I have been working with the Tamil Nadu government since the past 15 years. I know the government has been very supportive. Patients come for dialysis, they are happy, but they are not even taking their own medications. So for the adults means they come for dialysis, they are not taking medications. So I cannot even advise them or think of advising them peritoneal dialysis, because most of them are illiterate and they don't have the environment to conduct peritoneal dialysis. The rooms may not be available, the safety, hygiene, and there are so much of worry. I have burned my fingers actually taking them for peritoneal dialysis. The government is supporting, but whether the patient really understands is my issue. So patient empowerment, and we have to give them the power, empower them, shared decision making should be there. Of course, prevention is the cure. Thank you for having me be part of the World Kidney Day. I don't have anything further to add to this. Try and prevent kidney disease is the underlying thing. Thank you so much.
Thank you, madam.
Hi.
Dr. Suganya, anything you want to
I
add?
just have a comment to make. Deepti, as usual, an excellent talk and really an eye-opening talk. We hardly discuss about these subjects in routine academic CMEs. I would like to just add, I think having recyclable PD bags and making the company have a pathway to get these bags and reuse them in a different way are something that we can only wish for and advocate for. But I think at our level, what we can immediately start doing is, I think all of us miss this in our discussion with the patients. None of us discuss waste disposal with our patients. We don't discuss it at a point at all. I've never done it till now. And I think moving forward, we all can, at least for the patients on PD, ask them how are they currently disposing of their bags and how they can be responsible in disposing of their bags. They might not be, the company coming and collecting it back, but at least they are safely disposed. And even the erythropoietin needles and many of these things, and we don't discuss this at all. I think that would be a good starting point, and which
It's a
all
big
of us
problem.
can do it
Actually, we have
immediately.
seen patients, adults itself having the bags and they don't know what to do it. And they've been told to do, dig and put it in. So a lot of problems are there. So finding an easy, eco-friendly way is going to be a big challenge.
I think that conversation can be easily had at our clinic. First, we learn how to do it safely ourselves, and then probably communicate the same to our patients and see how much it translates into real practice. That is something that can be readily done, I feel. Yeah. Any questions from the audience?
I want to ask you a question.
Yes.
Dipti, you said incremental dialysis is nothing to do with the other prevention. That is one dialysis a day kind of thing. At what stage you start the dialysis? At what GFR you start the dialysis?
Ma'am, we go by clinical condition in the pediatrics. It's not like a particular GFR, but it probably in glomerular cases, glomerular diseases, we are forced to start it early. Although I say that it is ideal to start when it is very low. but then children do not, they go rapidly into pulmonary edema, especially the glomerular cases. So those cases we do end up starting early. But in tubular cases progressing to ESKD, probably suppose it distal artery, which doesn't happen, but or maybe a PUV which has progressed to ESKD, as long as they have a good urine output, and the parents are also usually very reluctant to start, and solute clearance is not much of a problem as long as we are able to manage medically with the acidosis part and the hyperkalemia part. We would wait for much lower GFRs compared to the glomerular disease. So I think there's no particular cutoff, but we can individualize, and wherever possible, we would like to start it at lowest GFR possible. And then the PD cycles also, instead of starting at a proper standard dose prescription at 40 ml per kg, if even at 20 or 25 ml per kg is providing me a good clearance with fewer exchanges, probably I can do that. And gradually, as his residual kidney function keeps declining, we can go up on the number of cycles.
Rehabilitation of the children will be much better with the machine dialysis at night, isn't it? They can rehabilitating the children. They can go for a machine dialysis at night.
CAPD, you're saying, ma'am? Yes, ma'am. That is what most of our patients do. So they, the mother, of course, doesn't have sleep, but the child is at least comfortable, and child is able to move around and do the routine activities during the daytime. So they try and do most of the PD cycles overnight.
Going to school and studying and all that.
Yes, ma'am. Also, because of the issues of vascular problem, we end up putting CAPD for a significant chunk of patients.
Thank you. Nice talk.
Thank you, ma'am.
Thank you, Dr. Bobity and the chairpersons. We move on to the next session, which is Decarbonizing Dialysis, Environmental Cost and Practical Steps by Dr. Jayalakshmi Seshadri. To chair this session, and I invite Dr. Radha Venkatramanan and Dr. V. Tamilarasi. Dr. Radha Venkatramanan is MD/AB, Internal Medicine and Nephrology. She is a senior consultant nephrologist at Vijaya Hospital. She is an excellent clinician and a guiding light, and was the treasurer of Women in Nephrology. Dr. V. Tamilarasi is a distinguished pediatric nephrologist, has made significant contribution to the development of pediatric nephrology in India and internationally. She has trained several generations of doctors. She was professor and HOD at CMC Vellore. She has innumerable papers and publications to her credit, and she has established hemodialysis centers in Ghana, Africa, and conducts free medical camps in Bhutan every year since 2007. She has received the prestigious APJ Abdul Kalam Award and the Dronacharya Award. We are honored to welcome the chairpersons, Dr. Radha and Dr. Tamilarasi, to start the session. Thank you.
Thank you for the opportunity, and good evening, everyone. It's a great pleasure for me to introduce Dr. S. Jayalakshmi, Professor at the esteemed Institute of Nephrology, Madras Medical College, Chennai. She had her education MBBS from Kilpack Medical College, MD from Stanley Medical College, and DM from MMC. She has presented several papers in renowned conferences and has several publications in national and international journals to her credit. She is an excellent academician and a great orator and a very kind human being. She has contributed a lot, very enthusiastically, to the growth of WIN-TL, and she has her special interests in hypertension, hemodialysis, preventive nephrology, and onconephrology. Over to her for the topic of this evening: decarbonizing dialysis, environmental costs, and practical steps. Madam, over to you, Dr. Jayalakshmi.
Good evening, yes, Jayalakshmi, you please come and give a talk so that we will have a discussion later.
Yes. I will start, madam.
Yes, start. Yes.
Good evening, respected chairpersons, esteemed WIN members, and all my dear colleagues. It gives me immense pleasure to be a part of this wonderful initiative. We would straight away go to the presentation. I don't know how to share the slide. How do I share the slide?
Madam, there is one green button, share screen.
Share
So
screen.
you have to
Where is it,
click on
madam?
that.
Yeah, the share screen, okay.
Yeah,
Ah.
just press it, ma'am. Yeah, your share. Yeah, okay.
Yeah, I'm sharing.
Click on that. And then it will lead you to your screen, madam.
Yes.
Okay.
Yes.
Great.
Yeah.
One second. Just
Actually, in CKD, the best modality of treatment is we must start with the conservative. Next, we'll go for dialysis. Dialysis will be this CAPD. Then what happened? Hemodialysis, transplant. Of all these things, best modality of treatment is transplant. But it is very costly. Because all people cannot go for transplant because of non-availability of the donors. But dialysis, if you take CAPD also to maintain for a longer period, it is very difficult because of in between intercurrent infection. Then what happened in hemodialysis? This is far off place. They have to go every other day. They have to at least 3 sessions in a week. They have to undergo. They have to depend on somebody must accompany the patient. Then in addition, what happened for a longer period? If they go for hemodialysis, it consumes lot of money. Then for each dialysis, this fluid what they are using is very enormous water they will use for dialysis. Per week, 3 dialysis at least they must have. Then only they can uh, continue the better for that lifespan. Then each dialysis 120 to 150 liters of water. So that for ordinary hemodialysis, for reverse osmosis, 400 liters. So annually, nearly 70,000 liters of water annually they have to use. Because of the hemodialysis, the plastics were in the 1 to 2 kg of plastic wastage. Then after electricity, imagine all these things. How to cut all these things? Please proceed, Dr. Jayalakshmi, wonderful associate professor in MMC. Start, please.
Thank you, madam. We will look into the green dialysis that is possible and a lot of thoughts about it. Greetings from Institute of Nephrology, Madras Medical College. Actually, our earth is dying unless we go green. So what is happening is that the global temperature is rising rapidly due to the rapid rise in carbon emissions, and freshwater supplies are increasingly threatened. So we as nephrologists should focus on the unmet need to reduce the carbon footprint in dialysis. That is very important because our dialysis is one of the most eco-unfriendly treatment available. It consumes a lot of water, causes a lot of carbon footprint, thereby damaging our Mother Earth. So we will just see what is possible. And why should we do it at all? Because if we are going to heat up Mother Earth furthermore and reduce all the water resources, it can again cause increase in kidney disease. Because of the heat, dehydration, and agrochemicals, we see that the AKI is increasing and the CKD-U that we've been talking about is also on the rise. And changing precipitation patterns, changing rain patterns, and so many things cause impaired access to healthcare and increase in non-communicable disease due to obesity and the other eating habits. Then urbanization, pollution, and alterations in biodiversity. When the planet Earth is getting a lot affected, the biodiversity also changes, unknown pathogens emerge, and we have a lot of nephrotoxic plants and vector-borne zoonoses. All these things are going to contribute to kidney disease. So unless we start putting an end to heating up of the planet and an end to the consumption of the water resources, we are going to face trouble. So providing environmentally sustainable nephrology care is very important. And you have had a lot of mini reviews and a lot of articles. This was from the KI, where healthcare on a global scale significantly contributes to carbon emission, with high-income countries being the primary culprits. Within healthcare, dialysis plays a significant role as a major source of emission. Low and middle-income countries have a high burden of kidney disease and therefore increasing demand for dialysis. So this actually causes a vicious cycle, thereby leading to more and more problems. So there is something called a lean service delivery. Lean service delivery is defined as the optimization of service delivery with the goal of maximizing environmental sustainability. This is basically optimizing. Something what we can compare this with is with supposing there is going to be a shortage of food. What are we going to do? We are going to ration it. We are going to give the people who need it most, the most amount, and whoever needs it less, the lesser amount. So rationing of whatever is available is the lean service delivery. We have to give it at the right time, the right amount, and to the right person. So basically, we should have a health promotion because early identification of kidney disease risk factors and early adoption of lifestyle therapies, which Mayuri had spoken about, is very important because reducing the kidney disease incidence itself is the best thing that we can do to reduce dialysis. And again, once a kidney disease comes, early identification of the disease, lifestyle therapies, and pharmacotherapy to prevent disease progression. This also has been discussed. Then non-dialysis therapies, wherever appropriate, conservative care, incremental therapies, as well as transplantation is something that is going to help us. Excuse me. Then once the dialysis is required, we should have a sustainably powered and produced low impact net zero waste kidney replacement therapy resilient to climate threats. This is something very, very nice to talk about, to tell, but in practice, it's going to be really difficult. But every minute of our time, we will have to keep moving forward to achieve this goal. Because, you know, everything has been told about water consumption. Energy waste is also there. Plastic waste is also there. So we have to see how all we can prevent this. What all we can do. Hemodialysis total global annual water consumption is about 265 million meter cube. Currently, 2/3 of this is potable, reusable water. But what happens is most of them go down the drain because we have to have an RO water where the wastewater is enormous. So main water supply comes to storage tank. We have all the filters. Then we have the reverse osmosis. But then the idea is to use this reverse osmosis water to basically do a lot of work like how we see here. We can use it the swimming. We can use it for the gardening. And then we can use it for the toilets. And we can use it for various recreational activities. Then, so what they say is that because of lack of awareness, lack of communication, there is lack of sustainability. So what we have to do, reduce the water loss and boost water efficiency, reuse water with minimal or no treatment within and outside the facility for the same or different process, and then recycle whatever you can, please recycle. So the 3 R's are most important in this. I have to mention about a pilot study which we did in our hospital, Madras Medical College, which has been discussed widely in various national and international forums. I would just like to highlight this study done by Dolphin, one of our postgraduate students at that time, ably guided by Dr. Shakti Rajan and Dr. Gopalakrishnan. Here, this was a single-center, non-randomized, open-label crossover pilot trial in patients with end-stage kidney disease on maintenance HD. What we did was each participant was subjected to 3 different dialysis prescriptions for 1 month. One is normal temperature, normal flow dialysis. The next one is high temperature, normal flow dialysis. And the third one is high temperature, low flow dialysis. The ultimate idea was to reduce the dialysis flow, thereby reducing the consumption of water required for dialysis, and just to see if it is effective enough. If we raise the temperature to a small extent, thereby having adequate dialysis, but not causing injury to the patient in any form. So the primary outcome assessed at the end of each dialysis session was the delivery of adequate dialysis, as defined by a single pool KT overview of 1.2. Outcomes were evaluated by comparing the NT-NF and HT-LF prescriptions. So the total of 863 sessions of HD were performed in 30 patients over 3 months. The primary outcome was not significantly different between the normal temperature, normal flow and the high temperature, normal flow, high temperature, low flow. So that means that when you have the normal temperature, you run the dialysate at around 500 ml per minute. With a high temperature, low flow, it's almost 40% less than that. So thereby you can reduce the water flow for the dialysis. But with a little raise in temperature, there was no significant difference between the two arms. The mean SP, KT over V and urine reduction ratio are not significantly different. Clinically evident hemodynamic instability occurred in only one dialysis session in the HTNF prescription. So there are about 287 sessions. Only one session had a little hemodynamic instability. So increasing dialysate temperature while reducing dialysate flow rate can be used as a water conservation strategy without compromising the adequacy and safety of dialysis, because we reduce the QD from 500 to 300, conserving water almost 40%. So this is the one that is represented in the picture form. Very simply, the run-in period was 1 month, then 1 month in each. The same patients were compared. So 40% reduction in the consumption of water with a little raise in the temperature without any adverse events. It actually resulted in the same dialysis adequacy. So hemodialysis, water intensive and water hungry treatment, they may have a negative impact on the environment. So the annual water consumption is what I told earlier. Up to 2/3 of water is rejected from this. So what we can do is we can reduce, reuse, and recycle. The 3 R's is very important. So reduce means various steps. You can delay the renal replacement therapy, thereby the requirement is reduced. And you can do an incremental dialysis whereby you don't have to give a blanket prescription of 2 or 3 dialysis a week. You can assess as much the patient needs and then you can keep giving. Even giving dialysis once a week or once in 2 weeks in certain conditions in a very small number of patients may be beneficial or enough for them. And reuse and recycle, the rejected water has to be used for constructive measures. Then education of healthcare staff and stakeholders is very important because they should understand what they are doing. And systematic application of this will really help us to have wonderful savings. So the next thing is the clinical waste. So what can we do? A total of 390 kg of waste, 101 kg of PVC has been generated in the HD. Similarly, in the PD also, there is a lot of waste generated in manufacturing and the bags that are going that have to be disposed. So 30% of UK's total clinical waste, they say, the NHS in the UK is from the dialysis. So what can we do? Incineration with emissions being done, but then emission is a problem. Then so much of waste generation has to be dumped. Then toxic chemicals are there if you dispose of the PVC. So what we can do, segregate the waste. Very, very important. That's what we do in the biomedicals now. Segregate the waste. Whatever can be recycled, do recycle. Whatever has to be incinerated, do it. And then any hazardous material can be substituted with better material which can be recycled. These things have to be thought about and systematically planned, experimented, and then it has to be advised. PD, again, it's been talked about in the last session. Again, the problem is about the disposal of the bags. And again, how much is spent by the industries and how much of carbon footprint is there in production of the PD fluid is something which people are not really disclosing. So we really don't know how much, but then somebody works on it and says how better is PD, it should always be welcome. So we can do incremental dialysis, delayed dialysis, reject water reuse or regeneration, and smart dialysis machines, where nowadays in dialysis machines, we have either a 300 or a 500 dialysis flow set. If it can be just in increments of 20 to 50 ml, then probably we can just keep as much as we need. Then again, we can have a solar and wind energy. Again, that is going to help us to generate better energy sources. Then heat pumps. The heat generated in dialysis can be used to heat some other thing, water exchange, water, the geyser, something like that can be used from the heat out of the dialysis. Then the next thing is biodegradable products for the waste and repurposing plastic waste. One thing that we have recently seen is our Dr. Ravichandran sir, who's actually doing the plastic material. He's utilizing it for doing certain useful items, or to reinforce concrete also it can be used. Then we can have the spent dialysate, whether it can be passed through various layers like this. Activated charcoal, urea, zirconium, and then pure water, can that be generated, is also under research. So probably if this is possible, we can actually absorb all the waste in these methods and then regenerate pure water again. And then about the variable speed motor pump, which we said, whatever is required for the water can be given in variable speeds. And then the rainwater harvesting is very important. We should not waste the rainwater because we're already in depth of water. Then dry concentrate mixing, whether you don't need the liquid at all, whether we can have dry concentrate mixing, and that will be helpful is another thing. Dry carbonate, bicarbonate mixing, all these can be really put into use. Some studies can be done to find out whether all these things are good enough, practicable, whether we can actually train the people in all these things and make the machines which understand all these things should be good enough. So preventive measures for the kidney diseases, then development of mitigation strategies, early screening and management to avoid advanced kidney failure, and then you will have to have developed environmentally sustainable treatments like all this that I said. And telemedicine, very importantly, COVID has taught us that so many things can be done sitting at home. Basically, we're all sitting at home and we are able to discuss so many good things. So this tele is always very important. This teleconferencing, similarly, a telemedicine, which actually doesn't make the patient come to the doctor, and you can have better methods of assessing the patients via telemedicine and advising them. That will also go a long way in reducing the carbon footprints. Then paperless clinical documentation, telehealth, as we said, and promotion of active modes of transport. All these things should always be applied. So our planet needs help. So are our dialysis patients. So what shall we do? I just had something to write down for this, which I had written earlier. It's hotter and hotter day by day. My green attire is fading away. That's what Mother Earth is telling us. Mother Earth is really crying with all this. It's hotter and hotter day by day. My green attire fading away. The ice cap running down as it melts, draining water into the bay. The fauna and flora so dear to me, a good number I seldom see. Climate has undergone a great change. Winds and rain all out of range. The Homo sapiens suffer and sweat. Hardly they know they are the cause, I bet. They misuse nature for their selfish zeal. Now they complain, fret, and feel. Oh, men and women of all the race, join together with passion and pace. Shun your pride and look at me as a whole. Take care of me, I am your soul. So Mother Earth is our soul. We will have to take care of her as we take care of our patients also. Thank you.
Actually, a very good discussion. She the way in which she presented how we can curtail the use of water, electricity, wastage product. Because of all these things, we are moving towards greener dialysis. So using this reverse osmosis, improved segregation, recycling and practice. What happened because of all these things, renewable energy sources, including solar power, to reduce carbon emission. In addition, we have home dialysis modalities such as peritoneal dialysis and home dialysis may reduce the infrastructure's demand and transportation. And another thing is actually they want the abroad and all, they have home dialysis, they have in the vehicle itself, they have taking the vehicle with 4 or 5 units hemodialysis to the house where the patients connect their electricity and do dialysis and dispose all the waste products and come off. This is very nice. We are not able to implement it here actually. John at the States, he was discussing with me when I went there, the New York, this type of dialysis, home dialysis. I discussed in CMC. We are not able to implement if it comes door delivery of the hemodialysis. This is very if you go for a discussion, it will be very nice. Hope it will come soon in India. I discussed in CMC, not able to implement. He's trying his best to bring the home dialysis, taking the vehicle with for 5 or 6 units within itself hemodialysis. Or there itself there will be a rest room, staff and everything will be after dialysis. This was waste product there itself. Very good presented, Jayalakshmi. Congratulations.
Thank you, madam. Thank you.
Thank you, Dr. Jayalakshmi, for that wonderful lecture, and also thank you for the chairpersons for the excellent chairing. Now, I would like to present a small overview. We are running out of time of the Win Tamil Nadu activities for this WKD 2026. So I have chosen, though we have done lots of activities, I've just chosen a few for want of time. So first is the place where I work, the Southern Railway Headquarters Hospital at Perambur. We had a PG awareness lecture where we emphasized on the planet protection to the students. We also had a World Kidney Day public awareness camp where we emphasized on the early detection of CKD and prevention. A skit was performed by our staff people, and one of the staff actually dressed up as the kidney, and what all the kidney undergoes because of the climate change and all the physical inactivity was enacted by our staff. There was also an exhibition on food, and the organ donors were honored. Savita Medical College, Chennai, where Dr. Indumati is the professor, also had organized a painting competition for the allied health personnel, and we can see the beautiful paintings and the active participation by the students. They also organized a camp where diabetics were screened for blood pressure, serum creatinine, and the urine albumin creatinine ratio. And they had a talk by Dr. V. Chandrasekharan on the cardio kidney metabolic syndrome. Uh, Krishnagiri is a place far away from Chennai, almost bordering Karnataka border, where a private hospital, ARK Hospital, where Dr. Shimna is the nephrologist, they had also organized this World Kidney activity, which went on for a week. They had a week-long exhibition, and they had a food exhibition too. And they had a patient screening camp to detect CKD, diabetes, and hypertension early. So from the government to the private sector, we go to Christian Medical College, Vellore, where Dr. Akshaya had organized again week-long activities. This is the awareness program for the college students where lectures were given. The sanitation staff at CMC Vellore were screened for the non-communicable diseases. There was also a kidney health screening program for leather workers. So near Vellore in Ambur, Vaniyambadi, there are a huge leather worker population who are below the poverty line and who are exposed to a lot of toxic chemicals. And they were screened free of cost for renal disease. And a poster session and a cooking session emphasizing on food. How do we use food as a mode for preventing renal disease was also organized, and a patient awareness talk was organized by them. They had also kept a pledge wall, and stalls for the World Kidney badge, bags, and books were also displayed. Coming to Pondicherry, Jipmer, here again, Dr. Bobby T. Deepthi, they had organized a PG quiz and certificates were awarded to the winners. So, Women in Nephrology Tamil Nadu every year conducts a screening camp for women, March being the Women's Day, International Women's Day too, with the help of Rotary Club and the WIN and the pharma company. We run a screening camp near Velacheri where the below poverty line females are screened. And this year we are planning to have it in April. So this is part of our community reach where we screen on the occasion of World Kidney Day as well as Women's Day on behalf of Women in Nephrology. So these are some of the activities, few of them, which we have done. Thank you. I invite Dr. Ranjini to conclude the session.
Dr. Radha,
Yes,
actually, see, in addition to all these things, personally, I do one thing. Every year, in my father's day, that is August 15th, we used to conduct a medical camp, just using the multi-stick, so that we can identify this, doing this, so that album, sure, everything we can abnormality find out, then recording a BP, taking the weight, all these things everywhere. Every year on August 15th, my father's birthday, I am doing it for the last nearly from 1995 onwards. I am doing it. Trichy Thurayur. This is all.
Congratulations, madam. You are an inspiration to us.
That is our personal thing. Every year we are doing. nearly all that village, that is Malayadivaram,
Yes.
Thurayur,
Yes, madam.
Trichy.
Yes,
Every year, August 15th, my father's birthday, I am conducting this, taking the entire village we are doing since my demise of my father, I am doing it. Of
Congratulations,
my
madam,
own
and you are an
interest, my
inspiration to the
family
younger
just join
generation.
and doing it.
Congratulations, madam. Now I invite Dr. Ranjini to conclude the Win Tamil Nadu's presentation.
Thank you, Radha ma'am. It was a great moderated session by your side. I thank all the presenters, all the viewers, and all the participants who had come in good numbers and gave a lot of boosting to the presenters. And I think it was a good, successful talk for this for this half an hour. It was quite engaging, quite informative, and a nice poem penned down by Dr. Jayalakshmi ma'am. I think it says a lot about what we need to do in the coming times and how we need to protect our planet. Also, last but not the least, want to thank Win India for asking us to be part of this, and also ma'am agreed to the thing that we have to come in the last and do our presentation because we were busy in the morning with some other presentation which was going on and organized by MMC. So deeply thankful to Swarnlata ma'am. She's been quite humble and like quite accommodative. Thanks a lot for all the opportunity, and I think we have done our job well. Over to you, ma'am. Swarnlata ma'am.
Yeah, thank you. I think before concluding, Urmila madam is here. I would like to, request madam to give a concluding remarks, madam. Urmila madam, please.
Good evening, all of you. All of you present. I have been in and out through the meeting, and I had the privilege of going through the works done by Telangana and then Tamil Nadu. And I thank you all for your activities. I will request all of you to create a sort of a project title or a sort of a presentation so that Win India can submit it to World Kidney Day and sort of our work and our activities are recognized. Thank you all. Thank you all. And I'm really proud the way all of you are working. Thank you very much.
Thank you so much. Goodbye.
Thank you, madam. I think it was a marathon from the morning. All the state chapters have showcased their activities. It's been amazing. So you could see, wide varieties of, diverse programs, right from screening programs of municipal workers, the leather workers, or the drawing competition, the essay competition. You name the activities, all has been conducted by all the states. It's actually kudos to entire Win India, the chapters.
There has been a lot of variety this time.
Yes, madam. Yes, madam. Yes, madam.
Quizzes, yeah, and all.
Exactly,
But
madam.
I still remember Ranjani Muthu's the last year's puppet work and all those things.
Yeah, that was amazing. That was amazing. That two thing I just wanted to conclude. One thing is, you try to, share all the activities. We'll try to put it up in the WKD, what do you call it, the world activities, so that
We create a
our
report
part
up from our side.
Exactly.
We just create a report.
Okay, man. The other thing is, 2-3 topics have come up. We really can, last time also we have tried, but I think it did not work out. But now I think both last year's and this year's, we should have certain article, article kind of a thing. You should be able to publish that, madam.
Yeah, all of
Madam,
you should write something, please.
Yes,
write
madam.
something what has come through from your thoughts and processes, the work that you're all doing.
Yes,
Please
madam.
write it up.
Yeah. I think I'll identify 2-3 people who can follow, and then probably next 3 months we can come up with a nice write-up, madam. And I would like to also thank Sai Vani. I think she has been really struggling to put everybody together, and I had to really, take her on toes for all these activities meant to happen. So thank you, Sai Vani, and if I've been harsh to you, please excuse me for that.
No, madam, no.
So thank you. Over to you for a conclusion, please.
East or west, Win India is the best. And
Wow.
from afternoon, we are listening about prevention from AP chapter on prevention of renal calculi, and Karnataka chapter on protein supplements and kidney health, and from Telangana chapter on carbon dioxide footprint, and from Tamil Nadu chapter, all the preventive aspects in hemodialysis and early detection of kidney diseases and its emphasis. And from North, we are sticking on the female health, importance of female health and Praki, a good discussion between Jasmine and panelists. And so we are overwhelmed with all the preventive aspect, and what we need to do is it should come to the practice side. Whatever we have learned today, we should practice. And so prevention is the best. So late initiation of dialysis and ideal time for dialysis initiation and prevention and protecting our planet Earth is the need of the hour. I thank everyone will adopt these practices in their day-to-day practice. And I would like to thank Swarnalata Madam for giving me this opportunity during as host of the World Kidney Day activity. And thank you very much, Madam.
Yeah, thank you. Before closure, I want to request everyone to please, attend this nutrition conference which is coming up, and our own group is one of the, the organizer win. So I request all of you to please, come and participate and share your knowledge.
And we
Today is
will
the last day for.
And we will release the finalists of essay competition during that nutrition conference.
Okay, I think we had to discuss that with the SRNM team. If they allow,
Yeah,
probably
yeah.
we can do that. But
Okay.
we'll find out if they are not allowing. We'll find out some other platform to release it. I mean,
Okay.
Sai Mani and Shiva Parvati, they are the quiz masters, and I try to accommodate most of the women also from all the chapter, at least one from each state chapter. So please, all of you, please come and then try to enjoy the conference and participate. Thank you.
Thank
Thank
you,
you,
ma'am.
ma'am.
Thank you.
Thank you, everyone.
Saivani,
Thank you, Saivani. Yeah.
Thank you.
Yeah,
Yes,
very
first
well
child out
done,
of you.
everybody. So kudos to you. I mean, you have threaded everyone
Thank
together
you.
beautifully, and I'm looking forward to have a nice video on all the activities done by all the states. So excellent. Okay, bye, everyone.
Bye. Good night and happy
Bye,
Sunday.
bye,
Happy
bye.
Sunday, Tata.
Bye.
Whatever is left of the
Very
India.
program we had it. I must congratulate everyone.
Thank you, madam.
Thank you.
Thank you.
Bye bye.
Thank you.
Thank you, madam. Thank you, Vijayalakshmi, madam. Thank you, Urmila, madam. Thank you. Thank you, Tamil Rasi, madam.
Yes, ma'am.